Okay, I think we should make start. Can you hear me?
Yes, I can hear you.
Excellent. That's great. Let me just adjust my mic a little bit. Okay, good afternoon, everyone. Assalamu alaikum, everyone. Thank you very much for coming to this INTERYem conference, which is the mental health conference. This is one of a series of many conferences dedicated to our colleagues in Yemen. So my name is Dr. Wahib Al-Azani. You may have seen my face before in previous conferences. My relationship to INTERYem is that I'm the international coordinator. I'm an orthopedic surgeon by profession, but I have special interest for education and training, and especially for our colleagues in the Middle East and particularly Yemen. The mission of INTERYem, which stands for International Network for Training, Education and Research for Yemen, is to facilitate collaboration between healthcare professionals from Yemen and the rest of the world. INTERYem is a non-professional, non-profit, non-partisan, non-sectarian UK-based NGO focused on developing the capacity of healthcare professionals in Yemen with the ultimate aim of improving patient outcomes. We do not advocate any political views and encourage our speakers to maintain impartiality and focus solely on clinical matters. The views of speakers may not represent those of INTERYem. We would like to keep this way so that we have the maximum impact and not to distract our viewers and our stakeholders. Our 6 key values are universal in their applications and appreciation. Number 1 is respect. Number 2 is excellence. Number 3 is professionalism. Number 4 is teamwork. Number 5, empathy. And number 6 is humanity. As applicants to the Charity Commission of England and Wales, we abide by the relevant legislations of the UK government as pertaining to England and Wales, as well as any other place we operate, for example, Yemen. To that end, our governance and due diligence is overseen by a board of trustees who must report our work to the Charity Commissioner of England and Wales. We hope to do work through exchanging ideas, sharing expertise, and building friendships in order to improve education and training of healthcare professionals in Yemen, and hence ultimately help the health of the people of Yemen. We believe that projects that build links between healthcare professionals in Yemen and the United Kingdom offer opportunities to make important contributions to building capacity and developing health systems. INTERYem is focused on 3 main aspects. Number 1, promote and facilitate the education of healthcare professionals and the public of Yemen. Number 2, encourage and organize high quality training for healthcare professionals in Yemen. And lastly, number 3, support and enable health-related research about Yemen and research by healthcare professionals inside Yemen. INTERYem's ambition is to facilitate long-term sustainable partnerships rather than just to focus on short-term gains. As sustainability requires dedication, consistency, and perseverance, it's important for partners to continue to maintain trust and communication. INTERYem does not wish to work in isolation from the healthcare context in Yemen. It's important for us to work within policy frameworks for the betterment of the current healthcare system rather than to consider certain structures outside the system. Ultimately, our vision is that we aspire for a Yemen where communities thrive through good health and healthcare professionals excel and inspire Yemen and the world. Many countries give mental health care a low priority. That's the case with Yemen too. Mental health was neglected for decades in Yemen, even prior to the current conflict. However, after years of conflict and trouble, mental health care in Yemen is in a particular dire state. For 6 years now and over, Yemen has been facing the worst humanitarian crisis in the world. The vast majority of population are in need of humanitarian assistance. It's estimated that around 20% of the people in Yemen suffer from a mental health disorder. That's a very, very significant number. Yet, resources to treat mental health disorders are abysmal. Some estimates put the number of psychiatrists in Yemen as low as 0.2 psychiatrists per 100,000. This is further compounded by the migration of mental health workers and more recently COVID-19. So as you can see, it's a very, very important issue that is facing our colleagues and our friends in Yemen. So training and continued clinical education in mental health is vital. And it's vital in the present and in the future. INTERYem has training, education, and research as three funding motives. We know that Yemen's healthcare workers are dedicated and knowledgeable, but often lack opportunities to develop in areas that needed for improving patient outcomes. We believe that the future of the health of Yemen's population resides in the capacity of its healthcare workers, and the more prominent the need for capacity building in a particular specialty to improve patient outcome, the higher it ought to be as a priority for training. Hence, the need to prioritize mental health in Yemen. INTERYem does not wish to and cannot replace training of mental health professionals in Yemen, but rather hopes to identify gaps in expertise and training, and then to try to fill those gaps and by exchanging ideas, sharing expertise, and building friendships with partners from the rest of the world. The identification in gaps in expertise and training needed by colleagues in Yemen is very much demand-driven. Training courses must be recognized as being required for the improvement of patient outcomes. The development of training courses in mental health should involve all stakeholders, including ministers of health and education, medical schools, universities, hospitals, students, trainees, and patients, so that a comprehensive understanding of the objectives for training can be met and delivered. However, mental health training, research, and education need to be resource efficient and realistic in their ambitions. To ensure quality, mental health training, research, and education should be developed using appropriate training models and accreditations from external bodies. A key aspect of INTERYem's mental health training, research, and education is dissemination of the knowledge and skills developed by participants to other mental health colleagues within Yemen who are unable to attend courses. Furthermore, knowledge and skills in mental health alongside non-mental health workers need to be a key priority too. The INTERYem Mental Health Conference, which you are about to attend for the next 2 days, has several objectives. As children's mental health is a particular concern, we will be having a dedicated session on mental health in children in Yemen. How to rebuild mental health services after conflict and years of under-resources needed to be carefully considered, and a session will be dedicated to this. Understanding cultural dimensions of mental health is a valuable asset for all practitioners involved in mental health, as often as it can be seen as culturally subjective clinical area. And hence we have included discussions of this in the conference. Finally, we hope to provide an update for mental health healthcare workers, or an overview for those new to the field. We will be having clinical updates. A key aspect of the conference is that speakers are able to provide practicable recommendations for Yemeni colleagues, and an emphasis is put on this too. Furthermore, the conference will provide an opportunity to exchange information by practitioners and academics in mental health from several countries. And this interplay will allow seeds of collaboration to exist. Finally, from a long-term sustainability view, the INTERYem Mental Health Conference will allow for the initiation of further and future work in training, education, and research in mental health. For those who wish to have a certificate, please fill in the feedback form at the end of the conference. The link for the feedback form can be found in your email, which you have provided when you registered for the conference. You need to attend at least 75% of the conference for a certificate. So please include your name and your email address on the feedback form and what you attended. On behalf of INTERYem, I hope that you will enjoy and benefit from our first mental health conference. And I would like to welcome your questions. Please be proactive, ask questions on the chat box. We also collect questions live on the YouTube channels. We will pass your questions on to our speakers for interactive discussion and answers. Thank you very much for listening to me. I would like to hand you over to our trustees for our trustee talk, and then we will commence the conference. Okay, Mubashir, back to you. Okay, we're just changing the permissions on Zoom, and as soon as that's done, you will have the next speaker.
And how
Dr. Mohammed, thank you very much. You just unmuted yourself. Excellent. Thank you very much. Thank you very much for coming on board.
Right. Okay. Thank you. So, Assalamu alaikum, everyone, and how are you? It's a pleasure to be in this conference. My name is Dr. Mohammed Bahgat Mohammed. I'm consultant at child and adolescent psychiatry in the north of England in Newcastle upon Tyne, and I work with the community team. I think we will be starting shortly our first session. I think it's really exciting topics that we will have today. And the first speaker is Dr. Shakil Ahmed. And Dr. Shakil is a consultant in child and adolescent psychiatry in North of England in Durham. We work together. He is a very clever child and adolescent psychiatrist. And he usually works in community, but with great experience in inpatient units as well. He will be talking to us today about updates in affective disorders and depression in children. So I'll hand to Dr. Shakil Ahmed to start.
Jazakallah khair. Assalamu alaikum. Hope you're all well. First of all, Jazakallah for inviting me to this conference. I actually don't have much experience with Yemen or with this organization. But when I was invited, I couldn't really say no, considering how important their aims are. So let me just share my screen, my presentation. Okay, can people see the presentation?
Yes,
Okay, fantastic. Okay. So the topic I was given was to discuss updates in diagnosis and management of affective disorders and depression in children. Now, I was only given about 30 minutes, which really cannot, you cannot even do the outline of it. And considering the importance of this conference, but also the complete difference in Yemeni situation to UK and Europe and most of the world, I thought I've attempted to make it relevant to the local healthcare professionals in Yemen. So what will I cover? So a little bit about me. So I'm Shakil Ahmed, also known as Abul Qasim. I'm a child and adolescent psychiatrist, and I work in Easington camps, which is in the NHS, part of the NHS community team. And this is, if you don't know where Easington is, it's in the northeast of England in the UK. So you can see on the map where the arrow, red arrow is, that's where we are. It's not far from Newcastle, and actually I live in Newcastle. And this is just a close-up map on the right of the locality. Now the locality is very, very deprived, mainly white locality. And actually, I think there are a few parallels with the Yemeni situations in terms of deprivation. Even though, alhamdulillah, there is no war here. So to extrapolate things actually for Yemen, it will be much more difficult. So I'll attempt to cover diagnosis, and I will touch on ICD-11 very, very briefly, because I don't think they are as important for the situation in Yemen. And also I'll touch upon guidelines for affective disorders and in particular depression. And I'll mention some of the challenges in Yemen and the applicability of research, guidelines, and diagnosis, etc., in the situation in Yemen. And I will also attempt to offer possible solutions, not because I'm an expert at Yemen or in this field, but mainly just as a starting point to sort of open up discussion and hopefully get people, local healthcare professionals, to give them some food to think about. And in the end, I'll close up with the main thing which I think could be used considering the local situation, which is diagnosis versus formulation split. And then inshallah, we'll end with the question and answer session. So first of all, let's quickly touch upon diagnoses. So I'm not going to read all of these. We all know, and I've been told that most of the participants here will be healthcare professionals, if not psychiatrists, then at least people, counselors, psychologists, etc., people who used to working in healthcare settings. So let's just quickly remind ourselves about the ICD-10 first, which is the outgoing version, and the ICD-11 is in place now. However, it has not been implemented in the UK yet, and I think it might be a year or so before we start using it formally here. So at the moment, we're still using ICD-10. And in terms of depressive episode, let's just remember that there are the three key symptoms: lowering of mood, reduction of energy, and decrease in activity. And of course, there are lots of other symptoms that have been listed in ICD-10. And the best way to keep up to date with this is to, if you search for WHO, World Health Organization website, and type in ICD-10, all the list is there with all the descriptions. So you don't really have to remember. So even the staff members who are not very experienced in this, they could quickly access this. But let's just remember also the last point, which is we classify depression in the mild, moderate, and severe categories, which is extremely important. Reason being, because the interventions are different for each class. So it's really important that we get the diagnosis right, and then we classify them according to mild, moderate, or severe. And then we start the interventions. And let's also remember there's also bipolar affective disorder, part of the affective disorders category. And that's characterized by 2 or more episodes. So this, And in this, mood and activity levels both are significantly disturbed, and you have to have at least some occasions of elevated mood, increased energy and activity. So you can call it hypomania or mania. So you have to have those, as well as some evidence of depression, but not always. But as long as you have evidence of mania or hypomanic episode, you would at least suspect bipolar affective disorder, even if you can't always diagnose it. And that's really important, because if anybody who presents with possible depression, it's always worth checking the symptoms for possible hypomania or mania in the past, because if we miss that and we prescribe antidepressants, for example, it might trigger the manic episode. So although this might not be a presenting problem, it's important that we check for this in the history. So coming to ICD-11, so again, it retains the mood disorders category, and it recognizes that there are different types. There are depressive episodes, manic episodes, mixed episodes, and hypomanic episodes. And also, so there are obviously diagnostic definition for depressive, bipolar, which are again is episodic mood disorders. But also it has it differentiates into bipolar type 1 and 2. So I won't go through this in the interest of time, but again, it's suffice to say that in the UK, we haven't started using ICD-11 formally yet. It'll probably take a while until we start using those. And I think in terms of Yemeni situation, I don't think it makes much difference, other than just that to access the access is available by the World Health Organization website. And if you just search for ICD-10 or 11, they're all there. Okay, so let's quickly move on to talk a little bit about guidelines. Again, it's a very large topic. There are lots of different sources of guidelines. And again, half an hour, it just doesn't do it justice. But also, I feel that in the Yemeni context, there are particular things that we should be highlighted, which I'll focus on instead, inshallah. So just a reminder, so within the UK, we mainly follow NICE, the National Institute of Health and Care Excellence guidelines. They produce lots of guidelines from physical health, mental health, in adult, children, in all different categories. And again, their website is open and free to use. And so for this guidelines, which is for depression in children and young people, for identification and management, the code is NG134. So if you search for that, it'll take you to that. And you can have a read, but all the details, it is quite detailed, and it is really sensible, really pragmatic guidelines. So this is the one we try to follow within the UK, within the NHS. And I've picked out a few factors which I think are would be really important to consider for patients in Yemen. Most people are aware, if you're working in the healthcare settings, about CBT and antidepressants, but I think the guidelines are much more rich and much more diverse than just those two things. So for example, family factors. Yeah. When a child or young person has been diagnosed with depression, we should really consider the possibility of their parents' mental health, substance use, other problems with living, because they are all associated with depression. And if we don't do that, then the treatment for the patient might not actually work. Okay, so in the Yemeni context, if there's war, there's poverty, there's maybe I don't know, homelessness, maybe there's mental health. Parents might have their own trauma, depression, grief, etc., etc. If we neglect all those and just focus on the child or the young person and their diagnosis, then really we're missing the point. We will be limited in our success of treating that patient. So this is recommended by NICE guidelines. Okay. So we need to think about family factors, but also social factors. So social factors, again, social networks, who's around them, what about, do they have any neighborhood support? Is there violence in the neighborhood? Is it safe? Is there any, are there grandparents around? Are there uncles, aunties around who could help, etc.? So these are all really important factors to consider before we initiate diagnosis, before we initiate treatment. So, okay, other things that NICE guidelines mention, which might be missed by people, is that actually it encourages for us to request young person to do regular exercise, not just one-off, and that's considered as 45 minutes to an hour. So for mild or moderate depression, this is really one of the starting points we should have, is encourage regular exercise, but also think about nutrition. So if there's poverty, there might be malnutrition as well. So these are all the factors we need to think about before we jump into the treatment, even diagnosis or treatment for depression. Okay? Because unless we address these factors, which are much more relevant in Yemen than in the UK, then really our treatment will not be successful, and we'll be wasting valuable resources, but also time, and the patient won't get better. Okay, so what does the guideline say about the choice of therapy? So again, the choice of therapy isn't just CBT as people perceive because of a shortcut. It actually depends on the child and their family. So we have to take into consideration their social history, their personal history, the maturity of the child, their development level, comorbidities. Do they have, for example, autism, ASD, or ADHD, or learning difficulties, or learning disabilities? Also patient and carer preference and values. And I would argue probably in Yemeni context, also availability of therapy. So if you don't have a therapy modality available, you can't really offer it. So choice of therapy is actually dependent much more on the individual and circumstances of the child and the family, but also the services. So this is all from NICE guidelines. Now for 5 to 11-year-olds, for moderate to severe depression, not mild, because people with mild depression don't need therapies, specific psychological therapies. It's recommended we start with the family-based therapies, and then we go down to the individual level CBT. This is different for the older children from 12 to 18. We start with individual CBT, and then we go to family therapy or other interventions if needed. So this is a really clear distinction. So NICE guidelines distinguish between 5 to 11 different therapies and 12 to 18 different therapies. Okay, so I'll just put a link there for, there's a very nice interactive flow chart on the NICE website. And here's the link. Now, if you go on there, it will tell you about the assessment, diagnosis, mild, moderate, severe, treatment, even medications. So just to quickly mention the medication part, so NICE recommends for moderate to severe depression only, we are able to use antidepressants, and only if the therapies has been tried and it's not effective, or the symptoms are so severe that patient can't engage in therapy, or if it's patient choice. And it's recommended as an adjunct to therapy rather than medication on its own. So this is really important part of the therapy, that actually medication is not seen as an alternative to therapy or a first line. It should be either the second line, or if the therapy hasn't worked, or addition to the therapy. Now, which medication do they recommend? Fluoxetine, starting at 10 milligram dose, and then after a week increase it to 20 if needed, and so forth. If fluoxetine hasn't worked, hasn't been effective, or patient experiences side effects, then before we think about alternative medication, it's recommended that we consider other factors like family factors, social factors that might have been missed, as well as compliance, before we go on to alternative medications, which could be sertraline or even citalopram. So just as an example, in the UK, we would usually start with fluoxetine, and if it doesn't work, then go on to sertraline. It is rare that we will try something different. Okay, so those were the quick and basic points about guidelines, about NICE guidelines, and how they possibly apply to Yemen. So I hope you can appreciate some of the factors from there that actually it's not as straightforward in Yemen than it is perhaps in UK. So this is actually, I just received this today in the post from one of the charities. So 6 years of civil war has left 80% of Yemenis completely reliant on aid to survive. So if people don't have enough to survive, then really mental health or even physical health will be much way down their list of priorities, but also affordability. Do they have access to mental health services? Can they afford the medication? Can they afford therapy, etc.? Okay, so these are some of the challenges from Yemen. So there's a resource challenge. Okay, we just heard before in the opening remarks that there are very few psychiatrists in Yemen. And my question would be, how many child psychiatrists are there? And I would imagine there'd be even less. And as an as a comparison, even in UK, we don't have enough child psychiatrists. But we have we manage. But if you go take it to the Yemeni situation, the gap between the need and the availability will be much higher. So really, we need to think, okay, how do we fill that gap? How do we maximize that gap? So what's the access to child and adolescent psychiatrists, psychologists, or therapists, or just any therapist, never mind just child-specific mental health services? So that's the first challenge. And then, okay, is there a system of primary care, secondary care, and specialist care? So for example, in the UK, we wouldn't see all the people with depression, all the young people with depression. Some will be treated in school by school counselors. Even GPs might, or our low-level CBT therapists, low-level mental health therapists might see patients as well. And then we will only get the severe end of patients who have really severe depression or very complex presentations. So really, is that available in Yemen or not? Or is it the case of there is nothing or highly specialist care? So really, we need to think about what sort of access this patient needs. Is there an access to therapy? So you've seen a patient, you've diagnosed them, you're saying, okay, they need particular therapy. Is there access to that? Can they afford it? Okay, if they need medication, can they access it? Can they buy it? And can they afford it? Okay, even if they can do all that, who's going to follow them up? And who's going to monitor if the medication has side effects, if the therapy is working? If it's not working, okay, what next? What should be the next part of the treatment plan? Okay, that all needs to be factored in. And lastly, affordability as well as availability. These are the big challenges, I'd imagine, in Yemen, particularly if the large part of the population can't even afford basic needs. So the challenges are huge. And in addition to that, there are diagnostic challenges. Okay, so who gives the information? So we know in mental health, we don't rely on, we don't have tests and scans and blood results to diagnose people. It's all about history taking and information. And really the quality of information is the key. And so if you, do you have that, who can, so you have a patient presenting to you, a child, who comes with them? Are there people who can give really reliable and good quality information or not? Because that's your limiting factor. Is there a stigma? Will that reduce the access to the mental health services? Or will people undermine all the symptoms? So for example, if a teenager is hearing voices, will they disclose that to the services or not because of stigma? The other challenge is how many people in Yemen that are seen have pure depression or pure affective disorder? And what percentage will have comorbidity? So I mentioned in the beginning, I work in a quite deprived part of the UK. And what I'm finding is it's very different from another service I used to work in the region. And that the patients are much more complex. It's very rare I find pure depression or affective disorder. There are usually family issues, drug and alcohol, family conflict, etc., bullying, school issues, academic achievements, ASD, ADHD. So there's a high level of comorbidity. And I would imagine that in Yemen, that would be the case as well. You would rarely find pure depression or affective disorders. And the chances are that most of them will also have possibly trauma or social stresses and poverty. Also need to think about, okay, do they have any confiding relationships? Are they adults or other people? The patients, young people, trust, they talk to when they're stressed. If not, then they have no outlet for dealing with the stress, and this will just build up. Do they have social support? What about the education system? Because we do rely quite extensively in UK on education system to help the young people on their process of recovery. And if they don't have that in a local area, in a particular part of Yemen, then again, that will be a limiting factor. Okay, so my last point on the challenges for Yemen is actually how much of the research applies to Yemeni situation? How many of the guidelines apply to Yemen? If you look into all the research about CBT or a depression or a bipolar or medication, in the exclusion criteria, they usually exclude really complex patients with comorbidities for trauma, for example. So if that is going to be the high number of cases in Yemen, then really most of the research doesn't apply to Yemen. And equally, most of the guidelines do not apply to Yemen. So how do we start? What do we do? And I would suggest that we use the research and the guidelines as a starting point, because we know those things work, but we don't stick rigidly to them, because the population needs and the comorbidity is very, very different in Yemen, as well as access to treatment, than in UK or most Western countries, or even most countries in the world. So this is something we really need to think about, which is why I don't think the guidelines are as important to Yemen. It's important to be aware of the main ones, so we know what the gold standards are. But in reality, you probably won't be able, you'll be limited in applying them. So what are the possible solutions? What do we do? So we have to think about resources and how do we scale them up so we benefit the maximum number of people. Okay, so we talked about lack of psychiatrists and mental health services, medicine costs, availability. So we really need, when we're assessing patients, we really need to think about what are the protective factors, what are the resilient factors. So now those could be child-based factors. So a child could be, okay, they've been through war, poverty, trauma, but what's working for them? Okay, do they still have friends? Okay, that's a protective factor, and that's a resilient factor. Are they still not severely depressed, even when you would imagine them to be? Okay, so what's stopping them from being even more depressed, despite all this gloomy outlook? Okay, do they have family who can help them, contain them? Do they have really good relationship? Okay, if a father might have died or mother might have died, but okay, is there a grandparent? Is there uncle? Is there auntie? Are there older cousins, older siblings? Who's there who can help? What's this person, this patient? What are the protective factors? What are the resilient factors? Is there a teacher? Is there a school who can sort of help them? Or is there like a local counselor or local, maybe perhaps a neighbor who can maybe monitor this patient, help them, get them out, help make sure they do exercise, keep an eye on their nutrition, etc., etc. So we really need to think about the protective factors and resilience factors. Okay. Now, thinking about resources, CBT is quite expensive, and it needs to be done properly, and you need to be trained to a certain level before delivering it. And if that's available, fantastic. But if it's not available, what do we do? Okay. So I think we really need to think about behavioral activation, especially in the Yemeni context. and not just for mild, but also moderate levels of depression. But even when somebody's in severe depression, or even with the bipolar affective disorder, I think behavioral activation is something that can be done very easily, very cheaply, and it can be trained to a really low-level qualified staff. So I think that's something that needs to be taken into account and really considered, especially in terms of the training needs of the country. And also, if we're seeing a child, a young person, we need to think of family as co-therapists because of resources, because of access, because of poverty. Family probably won't be able to access mental health services, formal mental health services, as often as they need. Therefore, we need to help train the family, even on a basic level, to act as co-therapists for the child, so that once they've been diagnosed and treatment has been started, they can actually then carry that treatment through. And behavioral activation would go perfectly with that. And again, we need to think about school-based interventions. What other interventions can the school do? Could we have a counselor in the school who could maybe help the children, and can we train them in behavioral activation, for example? And that way, with the very cheap and minimal resources, we can really scale up in meeting the needs of the community. And lastly, the really experienced mental health staff can actually train other people, and once they've trained them, they can supervise them. So for example, you could train lots of counselors or mental health workers within the schools or within the really needy communities. And then once you've trained them, they deliver the interventions in those communities rather than the mental health staff. But the staff actually supervise those people. So that way you'll know that you can be assured that there's a quality. And if they highlight someone who is severely depressed, for example, they need specialist mental health services, then they can be seen by the mental health services. So I think we really need to think differently. I'm not sure exactly what the situation is in Yemen in terms of services. Perhaps this is already there on the ground, but I think this is the part that really needs to be strengthened. Okay? Because we cannot wait to train the mental health staff, because that takes years. We really need to think about how do we train other people and then supervise them so that there is that quality that's maintained. Okay, so we need to think about, okay, once we diagnose somebody with depression, it doesn't actually tell us anything. It just tells us they've got these symptoms that are listed in ICD-10 or 11. It doesn't tell us anything else. So we really need to think about a formulation-based model. And I think the medical model doesn't work even in the UK. So we really need to think about very comprehensive model of formulation so that we understand where the patients come from. Why have they developed these symptoms? Why have they become depressed, or they have the bipolar has been triggered? And then we will be able to change our interventions to their particular needs. So first, we need to understand the problem and then treat. Okay. So when we see patients normally, the end of the arrow, the presenting problem, this is where they present. They say, oh, I'm feeling so depressed, I'm having suicidal thoughts, or or their parents bring them, they're not themselves anymore, they don't go out, they don't see their friends. And that's just the tip of the iceberg. That's just the end of the journey for them. Question is, what are all these other factors that have already happened? So what made them vulnerable to developing this depression? What triggered it? And what's keeping them depressed? What's stopping them getting better? And what's helping them? So we need to think about all these, we call them the 5P model of formulation: presenting problem, protective factors, perpetuating, precipitating, and predisposing factors. So this is the 5P model here. But also we need to think about, okay, what are the social needs, the social factors that are feeding into this? Is there lack of school, poverty, they don't have enough food? Are there social issues? Is there violence? Is there trauma? Do the parents have mental health problems themselves? But also biological factors, for example, are they in physical pain? Do they have physical health issues? Do they have family history of mental health problems? So hopefully, if there's one message from this presentation, needs to be that we need to not think about just the label or diagnosis or what the person sitting in front of us is telling us. We need to think about what's happened behind the scene, what's led them to this situation, what are the predisposing, precipitating, perpetuating factors, but also what are the social issues, what are the biological issues, what are the psychological issues. Once we have all this understanding, then we'll know, okay, the answer is not medication, antidepressant, answer is not CBT. Maybe the answer is, for this person, perhaps we link them in with their relative who might be able to supervise them better, or with a relative who might be able to who they have a good relationship with, so that they can confide in them. So when they're stressed, when they're very low in mood, they can talk to them. Yeah. Yeah. So at this point, I think I have run out of time. We have just enough time for questions. So I'm not sure how we're going to do the questions. I have one in the chat. Okay, so the question, shall I read from the chat?
Yeah, I think we said people can put their questions on the question and answers, and if anyone wants to ask like the question verbally, they can raise their hand. So you can start with that question in the box.
Okay, so the question is, as you mentioned, we have a very poor infrastructure for mental health services and scarce, if any, child and adolescent structured services. Okay, so we need all the help to help build the capacity through formally accredited program to leverage the services. So this question about access is really important, because if you don't have access to CBT therapists, then you can't implement the NICE guidelines. It's just not going to happen. And how do you get CBT therapists? Well, it takes a long time to train them, and it's very difficult to do that. But also, if you don't have child psychiatrists, okay, you'll have to do with adult psychiatrists then, until you get more child psychiatrists. So really, I think we need to think about the tier service. Okay, so you might have, for example, very few centers within the whole country of actual children's mental health service, who might only have one psychiatrist and maybe one psychologist or a couple of nurses or therapists. That's it. So how do you then treat people in all the surrounding villages and towns where there are none of these clinics? And I guess the question is, okay, not all of them will need specialist psychiatrists or psychologists or therapist services. Most of them will be okay with low-level interventions, but somebody needs to train those people, for example, in schools and local communities, and somebody needs to then supervise those people, so that they know that actually if they're struggling with any particular thing, that they have somebody they can ask and get feedback from, and they can learn more from. And over time, those people in those local areas who are not formally trained, who are not formal psychologists or therapists, you could call them local mental health champions or local mental health counselors, etc. That's possibly one way that you could scale up and use the very small resources and actually magnify them within different communities. And any patients who are really, really severe, they actually need specialist mental health services, then they can then feed them through to the specialist clinics.
And I think that the other thing, Dr. Ahmed, that currently what we saw on the pandemic, it gave the opportunity of virtual training, virtual communication, even virtual clinics. So that might be another thing that I'm not sure how possible that would be, but I think this is an area where you can get training online now. It doesn't to be from someone in Yemen. You can get even from UK people, some therapists who can train like professionals in Yemen. And I'm hoping that INTERYem will have a role in this communication.
Exactly. And I think the pandemic, you're right, has shown, actually, we've done a lot of group-based CBT sessions for our patients online, because we were not allowed to have them all within the room. Usually there'll be 10 or 14 of them would come in one room, and our therapist will run the CBT group or DBT group. But because of the pandemic, we've not been able to do that. So they've delivered it online. It has its challenges, but we know it can be done. And specialists in Yemeni situation, we don't really have a choice. We have to think outside the box. We have to think, how can we train? Where can we get the training from? And who can we train? Who's able to just deliver that?
Yeah. Thank you so much for your presentation. I enjoyed that, and that holistic approach to diagnose and to manage is really important. Actually, can I just ask a question? Because it's interesting that we know children and adolescents might be presenting differently when they are depressed. So having that conflict in Yemen would make it even more complicated. So as a diagnostician or as a professional, what sort of thing that the child might be presenting with that I need to consider depression or affective disorder as one of the differential diagnoses while I'm just assessing this a child?
Yes, exactly. So even in I've moved a job from one area to another. It's literally 20 miles away, and I found a massive difference just because is poverty. It's more deprived area, and this is still within England, in UK. And if you take that and the difference is there's a lot more comorbidity, and it's patients don't recover as quickly because the family factors are not there. And you need a lot more social support and school-based support. So without our team, CAMS team, linking with the schools and social workers, we just do not make progress. Whereas when I was in the other locality, I could just tell the parent, explain to them, and between the child and the parent, they will just make progress. They'll just do all the interventions. So whereas in Yemen, you have high level of trauma. So, if there's war, there's poverty, chances are a lot of children that you see, patients, they would have lost somebody to the war, or there would be poverty, malnourishment, etc., etc. And so I think comorbidity would be the rule rather than the exception. So which makes it even more important that we adopt a holistic approach, not just listen to the symptoms, diagnose somebody, and give them treatment. I think we really need to think about all the factors like formulation. What are the social factors, psychological factors, and that will tell us where the best intervention needs to be. And the answer might be, actually, you don't need a psychiatrist for that person. What you need is maybe a local masjid imam, who's actually quite good, who runs like a children's group, or in a madrasa, for example. Actually, maybe you train one of them to in a little bit of counseling, and they might be the best chance for that child, for that patient, to get better.
I think this is really important point, because I completely agree that you mentioned the stigma earlier on, and it is unlikely in our countries, like in Middle East, in Yemen. I'm originally from Egypt, so even in Egypt, just to bring a child, my son, to a psychiatrist, so it's more likely that I'll go to speak to one of the relatives than the imam of the masjid, or even the teacher. So I think as mental health professionals, we have got that responsibility to increase the awareness among those people about the element of possibility of mental health issue, and how to guide or to lead or even to manage sometimes if it's something simple or mild.
And I think it's becoming really clear through this conference to me, somebody who's never been to Yemen or know much about it, that actually the challenges are massive. And as a mental health professional, there is no way you could ever meet the needs of your population. So you have to use other resources. So you, as a mental health service, train other people. So run a group like once a week or once a month, a group of say from one village or one town, all the imams or some teachers, and teach them about mental health, just the basics, how to recognize, about stigma, what is behavioral activation, what is counseling, and do that, once a month, every month. And that way you can actually help so many more people than you as a little team or a service would ever be able to reach them.
Yeah, yeah, thanks so much.
And I think stigma, you're right. I think I would say that actually not just say imams, but also schools are another thing. I don't know what percentage of children in Yemen actually are still going to school or not. And does that differ between primary and secondary school? But I think the school system is a really good way of addressing trauma and addressing the raising awareness of mental health difficulties.
Yeah. I think the other thing is, I'm sure here in Newcastle or in UK, we started to see some children for families who are asylum seekers. And we know that this would be like the last step in the very long journey. And we know from the history that we take how they suffer initially. And they usually say by that time when things started, they don't consider mental health as a priority. They look for safety, as you mentioned, like initial biological needs to satisfy first. So do you think that there's anything could be done even to help children and young people like to identify their needs at this stage, considering that they are not going to come to say we are suffering?
Yeah, you're right. And from a very few refugee children I've seen, they're normally very close as well. So they won't, because they don't trust anyone. They've been through so much. They close down. They don't trust people. So even as a mental health professionals, they just won't disclose much. So the best chance of getting understanding their needs is through somebody they trust, they know. So family member or whoever they're living with, or the local person, the local community, people they're familiar with. So if you struggle as a mental health service to engage that person, find out who do they trust, who do they know, and maybe work through that person. Because you're right, and especially with somebody has been through a lot of trauma, a lot of difficulties, and moving and being refugee, even within the country, the basic needs are not met. A lot of them just stop trusting people, and so you might have to work through people they know, but also it might be a long-term thing. You just might have to build the relationship or identify a person who can build a relationship with them over time. And you can do that through non-therapy methods. So for example, organizing local, football match or local play, something non-mental health related. Because I found even in UK, boys tend to engage more talking about the emotions when they're doing some activity. So even with my nephew, for example, he would never talk about his feelings, or even though I can tell he's really grumpy. But if you go for a walk or if you go play something, and then while you're playing, you can chat casually, and they will open up. So I think that's another way, play-based therapy for younger children, we do that, but even for really there's no reason why we can't do that, especially in the Yemeni context with the older children. So perhaps there's a argument to be made to do some counseling, etc., low-level mental health intervention work in Yemen through sports.
Yeah, I think this is a very good idea. Right. So thank you so much, Dr. Ahmed. That was very interesting presentation and discussion. We are now moving to the second part of the session.
Jazakallah.
Jazakallah khair. Thank you so much, Dr. Ahmed. Thanks. So this one is about post-traumatic stress disorder among Yemeni children due to ongoing conflict. And this is by Dr. Fawzia Al-Ammar. Dr. Fawzia is a specialist in the field of education psychology, psychological and educational measurement, and she is a researcher in the field of mental health and gender studies at Amran University, Republic of Yemen. She holds a doctorate degree from the International Islamic University, Malaysia in 2008, and then did postdoctorate research related to psychometric at the same university in 2012. She works as a lecturer and researcher at the Center for Research and Studies on Gender and International Development of Sanas University. She has work experience as a consultant with several research centers and international and local organizations. We are going to start by showing her video first, and then we'll take it from there. I don't think we can hear the voice. Yeah. Because we missed the first part. You can hear it now. Yeah, thank you.
أن أشارك في هذا المؤتمر بعرض نتائج دراسة ميدانية تناولت أضرار ما بعد الصدمة في أوساط أطفال اليمن. عرضنا سوف يتناول التأثيرات النفسية للحرب في أوساط اليمنيين، وكذلك الأبحاث التي تناولت هذا الموضوع وأهم النتائج التي توصلت إليها الدراسة والتوصيات المتعلقة بالموضوع. من شوط الحرب في 2015 استمرارية ألقت بخسائر فادحة على حياة الأطفال لأسباب عدة، منها ما يتعلق بالغارات الجوية، الهجمات المسلحة، التهجير، النزوح، وسوء الأوضاع المعيشية. كل هذه الظروف أدت إلى تعرض الأطفال إلى الصدمات النفسية الكبيرة. فكما تعلمون أن الوضع الإنساني في اليمن حسب تقديرات الأمم المتحدة 80% من السكان هم بحاجة إلى مساعدة إنسانية. يشكل الأطفال في هذه النسبة ما يعادل 12 أكثر من 12 بحاجة إلى مساعدة إنسانية. والأطفال بطبيعة التدمير النفسي الجسدي يكون أكثر عرضة للصدمات والمعاناة النفسية. وأمام هذه الحاجة الماسة لتناول موضوع الصحة النفسية في اليمن، نجد أن الأبحاث التي تطرقت لهذا الموضوع محدودة وقليلة وشحيحة، باستثناء الدراسة التي نشاركها معكم اليوم، إضافة إلى دراسة قام بها مركز التنمية والإرشاد الأسري في صنعاء. أشارت نتائج هذه الدراسة إلى أن نسبة اضطرابات الصحة النفسية وصلت إلى 16.4 لعينة من هذه النسبة خلال دراسة عينة واسعة تناولت دراسة من 2014 إلى 2015. النتائج التي تشير إليها دراستنا أيضا تشير إلى أن نسبة الانتشار لموضوع ما يعرف بأضرار ما بعد الصدمة أيضا عالية، وهي مؤشر للخطر ويهدد مستقبل أطفالنا بسبب الظروف والسياق المجتمعي الذي يعاني منه المجتمع اليمني وبينهم الأطفال. سوء الوضع المعيشي والأمن الغذائي والاقتصاد الوطني وسوء تدهور العملة وتوقف الرواتب بالنسبة من السكان، إضافة إلى جائحة الكوليرا وجائحة الكوفيد-19، إضافة إلى الخدمات الصحية الأساسية. الأبحاث التي تناولت هذا الموضوع شحيحة ومحدودة. أي نعم، هناك دراسة تناولتها سيف الجبرن ودراسة أخرى قامت بها منظمة محلية، إلا أن هذه الدراسات لا زالت محدودة وبحاجة إلى اهتمام كبير من الباحثين في هذا الموضوع سواء في الداخل اليمني أو قبل المنظمات الدولية. عرضنا الحالي سوف يتركز على الأضرار التي تسببت فيها الحرب التي نشبت منذ 2015 وحتى الآن، بالتركيز على الأطفال النازحين الذين في خلال العام الدراسي 2016 في مدارس الحكومية بمدينة صنعاء. تم جمع البيانات هذه الدراسة خلال خلال شهري أبريل إلى مايو في نهاية العام الدراسي 2016، أي بعد سنة من نشوء من بداية الحرب التي نشبت في 2015. استهدفت الدراسة مجتمع النازحين، الأطفال النازحين في أمانة العاصمة، الذين بلغ مجموعهم حوالي 10,000 نازح ونازحة من الطلاب في المرحلة في مدارس التعليم العام، ابتداء من الطلاب الذين أعمارهم الدراسة استهدفت الطلاب الذين أعمارهم من 8 سنوات إلى 18 عام، بمعنى جميع الطلاب في مدارس التعليم العام من الصف الأول الأساسي إلى نهاية المرحلة الثانوية. إلا أن جمع البيانات عن طريقة جمع البيانات باستخدام الكاركتر سامبلينج متعددة المراحل، العين الأول متعددة المراحل باستهداف ما يعادل نسبة 10% من المجتمع، حيث أن الدراسة كانت العينة ممثلة للمجتمع. بلغ الطلاب المشاركين في هذه الدراسة حوالي 900 وطالبين من الأطفال النازحين في مدارس أمانة العاصمة، الذين استجابوا ل 17 عبارة من عبارات مقياس أضرار ما بعد الصدمة والمسمى بشان PTSD symptom skills. بالمناسبة تم جمع هذه البيانات من 16 مدرسة في مديريتين مديريات أمانة العاصمة بنية السديد وصافية. خصائص العينة التي جمعت منها البيان كان حوالي أكثر من النصف 52% من المشاركين هم الأولاد مدارس الأولاد، و48% هم المشاركين الإناث من الطالبات في متوسط عمر 14 سنة، ومعظم المشاركين هم كانوا من الصفوف المتوسطة اللي هو الصف الثامن والتاسع، و18% من الصف السابع، وبقية النسبة كانوا من المراحل الثانوية. المشاركين الطلاب المشاركين في هذه الدراسة كانت خلفيتهم الأسرية حجم الأسرة حوالي 8 أفراد في المتوسط، ومستوى دخل متوسط إلى متوسط مستوى دخل وفقا للمعايير اليمنية. بسم الله الرحمن الرحيم. استخدام التقنية الإحصائية التحليل العاملي والمسمى Principal Component Analysis. أشارت نتائج الدراسة أن النتائج إلى 3 أنواع من الأعراض النفسية. أولها الأعراض الاجتماعية الانفعالية، وأعراض ذهنية أو معرفية، وأعراض سلوكية. بالنسبة للمجموعة الأولى والمكونة من 6 فقرات أو 6 عبارات شملها المقياس اللي تجمعت حول الأعراض الاجتماعية والنفسية عفوا الأعراض الاجتماعية والانفعالية، كان متوسطها 10 درجات، وهي تشير إلى مدى معاناة الطلاب نتيجة مرورهم بخبرة بالصدمة التي مروا بها، بينما الأعراض المعرفية أو الذهنية هي تشير إلى mental health activities، إلى الخيالات والأنشطة الذهنية التي يعاني منها الأطفال بعد مرورهم بالخبرة الصادمة، بينما الأعراض المتركزة حول الجانب البيهيفير السلوكي تناولت الاضطرابات السلوكية التي يعاني منها الأطفال نتيجة مرورهم بالخبرة الصادمة. المجموعة الأولى نلاحظ أن النسب تراوحت بين 70 إلى 60. 72% من الطلاب الذين قيموا نفسهم بأنهم ليس لديهم يعانوا من عدم قدرتهم على التعبير بالفرح أو البكاء، يعانوا من مشاكل انفعالية. و 67% من المستجيبين قالوا بأنهم أقل رغبة في عمل الأشياء التي تعودوا يعملوها. 70% يعانون من صعوبات في النوم والاستيقاظ، و63% من المشاركين الطلاب يعانون أو لديهم شكوك في مستقبلهم. 62% من المستجيبين يشعرون بميل إلى الانطواء ومن أصدقائهم والمجتمع المحيط بهم، وبينما 61% من المشاركين لديهم مشكلات انفعالية يعني أقرب إلى النسب وسرعة الانفجار، فيعانون من عدم ضعف التحكم في قدراتهم الانفعالية. نأتي إلى المجموعة الثانية واللي هي الأعراض المتعلقة بالجانب الذهني أو المعرفي، نسبها مرتفعة حوالي 79%، الذين قالوا بأن تتكرر لديهم الخيالات والتصورات كأن الحدث يحصل لهم للمرة الأخرى. و72% يعانون من اضطراب الأفكار، وتكرار صور الحدث الصادم تتكرر إلى أذهانهم، بينما 71% يحاولوا أنهم يتجنبوا التفكير في موضوع الحدث الصادم لكنهم لا يعجزون عن ذلك. 69% يعانون من الأحلام المزعجة، و63% يحاولوا أنهم يتجنبوا الأماكن والأسماء والأشخاص والحوادث والأشياء التي تذكرهم بالخبرة الصادمة، بينما 61% لا يستطيعون تذكر الحدث الهام المتعلق بالخبرة الصادمة. المجموعة الثالثة هو الأعراض المتعلقة بالجانب السلوكي. 83 من الطلاب يشعرون بالحزن والاضطراب عندما يفكرون بالحدث الصادم.
Right. So we do apologize. I think Dr. Fawzia has tried to connect, but there's an issue with her internet. So we managed to show the video. She sent like 3 parts for her presentation, and we looked at the first and second part. Unfortunately, the third part didn't work. And she's not currently with us, but I think that her study is really amazing. I'm really impressed by the work she did, and I wish she was here today because I've got many questions. I wouldn't be able to comment about the details, but by the look of it, the numbers are horrific, to be honest. The number of kids affected, which is expected, and how this is affecting their feeling, their way of thinking, and their behavior. this is very significant. And I see, if I'm talking about my practice here, I see kids with some kids with post-traumatic stress disorder, and this is usually related to trauma in early childhood, which could be anything from sexual abuse or any sort of abuse, having an accident or things like this. But this is nothing compared to what children in Yemen are suffering from with this war, with this huge stress and trauma. And that's why the numbers, as we can see, is really high. It, it wouldn't be helpful if we know more details about like the effect of those like things on the achievement or the performance of those children, both at social life and at their academic life, if they have some. I don't know if you have got any questions, because at the minute we haven't got Dr. Fawzi, but we can discuss based on the presentation that we just had. So to summarize, probably if I can remember the number, she's talking about big number of children, and nearly more than two-thirds of them, like around 70% of them, are giving yes answers for the effect of the trauma they had and the feeling in the way they think and the view about the future and their performance or behavior. And the very important question is what could be done to help those children. I'm honestly not familiar with the mental health system at Yemen, and whether we know there's a huge lack of resources, but whether anything has been tried with those children. We know here the main work around trauma is trauma-focused CBT as one thing, but the other thing, which is eye movement desensitization therapy, and the outcome of the second one is really good, and it would be like an idea whether people could be trained on the EMDR and then to deliver this, because I'm sure there's a huge need for this at Yemen. Right. I think now we will move to the third presentation, and the third presentation is for Professor Mothana Samara, and it's about development of psychopathology in children on their journey from war, trauma to refugee. And Prof. Samara is a professor in development psychopathology and head of developmental psychology research group. His major research interests are in school and sibling bullying, the long-term outcomes following prematurity, and the development of post-traumatic stress disorder amongst children of war and refugee. He has been awarded as a lead PI several grants in different topics: the cyberbullying study, the development of PTSD study, the development of premature children, QPRIM study, teens taking charge for cancer patients, and school experience, educational aspiration, and scholastic achievement. He is the co-director of the Center for Research on Communities, Identities, and Difference, and the head of the International Center on Children and Adolescent Psychopathology. He is the editorial board of several journals, and his research appeared in several media platforms. He is a psychologist and holds an associate fellowship with the British Psychological Society.
That's for sugar. A for alpha, M for mother, A for alpha,
can we make sure that everyone microphone is mute, because I guess some of the microphones are not mute. Right. Sorry, we have got question here before coming to the presentation. So this is from Antonella Pozzi. Hello, I am a psychologist working with MSF in Hijaz City and we are having also a very high number regarding psychotic patients, around 40% of patients in our clinic. At first, I thought the number were wrong, but seeing this specialist numbers, I see the numbers regarding every pathology are very high. This is about a bit shocking, to be honest. 40% of the patients in the clinic are psychotic. I don't know what is the age group you are dealing with, but 40% is a very big number, isn't it? And it would be helpful to know this within the community, what the percentage of the psychotic patients within the community rather than within the clinic, because within the clinic it would be a bit biased by those who are really stressed, who are coming to the clinic. But I agree, it looks like the trauma, the war, and the conflict is exaggerated. We all know that any mental health problem would be like exaggerated and triggered by such a huge like conflict. I think the good news is we have got Prof. Samara here, so I'll invite him to start his presentation.
Hi.
Hi.
Can you hear me, Bill?
Yeah, I can hear you now. Thanks for coming.
Yeah, you're welcome. I thought my presentation is in 15 minutes.
Yeah, sorry, Dr. Fawzia, the second speaker, couldn't manage to come because of Wi-Fi issues, technical issues. So we had to show her video, and we finished that a bit earlier.
Okay, no problem at all. Good that I came earlier then. Thank you so much. I will just take a few minutes just to prepare the
it's absolutely
my screen. I'm just closing things that they will not pop up during the presentation, like the emails and the noise. Okay, I'm just sharing my presentation. Can you see?
Yeah.
Okay, thank you so much for inviting me for this interesting conference. And it's a privilege for me really to share with you my research and my experience with research with children who have been exposed to trauma, whether in war zones or as refugees during their way outside of their outside of the war zones. So today I will talk about the development of psychopathology in children and on their journey from war trauma to refuge. What are the challenges they face inside their own countries, and as well as some interventions that we have performed before and now. As well as I will also talk about health services and some maybe new ideas for interventions, taking into account the challenges in war zones and for refugees. So my name is Muthanna Samara, and I'm professor in developmental psychology at the Department of Psychology at Kingston University, London, in the United Kingdom. And it's very, very important for me, I think, it's to put things into context, trauma in context, because knowledge about developmental stages will alert us to the fact that some problems and or problems in behavior is normal at some stages in life. specifically when we are talking about trauma in this case. However, it's also normal for some children who are living in peaceful environments. So, for example, let's say a 2-year-old who is not distressed by the separation of the mother, we would expect that there is some problem with that specific child. Or an overly obedient 3-year-old, we will expect these children to be more active and maybe not to be obedient at some points. If they are obedient all the time, then there's some sort of a worry. So sometimes the absence of abnormal behavior is a worry for us. And I will just give you an example of my daughter. I took her to see the fireworks at a specific point here in the UK, and she was so scared, and she was crying when she was hearing the noises of these fireworks. Although it's a happy environment, but for that child at that specific moment, it was too much. And thus, what I'm trying to say here is that the victims of war react normally to abnormal conditions. It's very important to put this into this context and to understand that these are the normal reaction of these traumas for these children, because it's abnormal condition, abnormal situation for them. So we want to avoid pathologizing children, adolescents, and adults as well, and say, or pathologizing normal reactions and problems. But at the same time, we have to take into account that we need to solve these problems and find solutions as well. And thus, if serious psychopathology is not identified, the valuable benefits of early intervention may be lost. And thus, we have to take this into account to establish suitable interventions. I will take the ecological model during my talk. The child is in the middle, but also the child is affected by various circles which are surrounding immediately the child, like siblings, family, parents, the close family, the extended family, and then the further environment like the neighborhood, the community, the culture, the ethnic group that they belong to, religion, as well as the political situation. And thus, we cannot take any individual or person in isolation of these circles. They all affect the child and the adolescents and the adult, and thus we have to take these into account when we talk about the development of psychopathology. There's a huge number of children who are living in war zones and in war situations, and political violence and the impact of the threat of terrorism is widespread. War traumatic events affect the psychological well-being of children, adolescents, and their parents as well. And to add to this, also affecting the practitioners who are supposed to deal with these problems, these children and these adolescents. And thus we are in a very complex situation where we need to take these into account as well. As a result, those who are exposed to war traumas, they are under continued threat to their life and sense of safety. They feel all the time that they are not safe. And there's disruption of their daily life activities, like schools, if they go to school, or to their work. And thus there is some sort of toxic stress that goes into this cycle of violence and trauma that these children and adolescents are exposed to. So when they are exposed to strong, frequent, and prolonged adversity without any support from their parents or adults or practitioners or health services, mental health services, this can disrupt the development of the brain and other organs, and thus will increase psychopathology as well as cognitive and emotional impairment. And thus the toxic stress happens inside the body as well. And these effects are likely to persist into adulthood, even after violence stops. Actually, after the violence stops, the work will start and problems will increase afterwards more than even during the war itself. And these conditions impair children's ability to engage in daily life, to focus and perform well in school, to form relationships with their peers, with their parents, even the attachment with their siblings and parents, and even to feel safe. Even when they are in a safe environment, they will still have triggers that they will feel unsafe all the time. Multiple exposures as well to violence, like war or violence inside the family, from siblings or in the neighborhood, will cumulatively increases the risk for psychopathology. And thus, without interventions, these mental health problems are more likely to continue into adulthood. And these untreated children and adolescents will continue in their adulthood to experience more problems. And thus research has found that those children who were in adverse childhood, who has experienced adversity during their childhood or adolescence, may carry 12 times the risk for alcoholism, drug misuse, depression, and even suicide attempts. They are more likely also to have physical health conditions, including heart disease, cancer, chronic lung or liver diseases. And thus we have to treat these early on before it goes to more problems. I will talk about several studies and I will give an example of children in Palestine as a case study, and specifically in the Gaza Strip. And as you may know, the Gaza Strip is considered as one of the most densely populated areas in the world. There's around 1.8 million people who are living in only 365 kilometers. The situation in the Gaza Strip is uncommon with regards to the frequency with which children are exposed to traumatic events on a daily basis and the long-term nature of the conflict. It started in 1948 with the grandparents or great-grandparents, and then it moves on to their, to the grandparents, and then to the parents, and then to their children as well. I can see that there is a hand raised up. Do you want me to stop or? Not sure.
No, please carry on. I think that was by mistakes, and by the end of the presentation, we will take all the questions. Okay, thank you.
Okay, thank you so much. And as you can see, for example, this is the map of the Gaza Strip, where there's a siege on the Gaza Strip since 2005. And you can see also not just the siege from the borders with Israel and the Egyptian authorities, but also even within the sea, they have fishing limits. They cannot go on into the sea and fish wherever they want. There's a prohibited fishing area that they cannot go on and do their fishing. So it's more stress even to income as well as to their socioeconomic status. Just a brief history of the Palestinian or war trauma in Palestine. I want to talk about the 1948 when the Nakba has happened. And then in 1967, when West Bank and the Gaza Strip, along with the Golan Heights and Sinai were also occupied. I will start from the first Intifada, or what it's called uprising, from 1987 to 1992, where there were clashes with the Israeli military because they were occupying the West Bank and the Gaza Strip. And then in the second Intifada, after the peace process during the 90s, the second Intifada started in 2000 to 2005, and the siege on the Gaza Strip started in 2005 until now. Then there were several wars that has happened. The first war in 2008 to 2009, which has lasted for 23 days. I will mention these wars because I did studies during these wars. There were around 1,400 civilians who were killed, including 313 children. In the second war in 2012, 8 days, that took 8 days. There were also lots of injuries at that time. And the third war in 2014, which has lasted for 51 days, approximately 2,200 children, Palestinians were killed, of whom 1,500 were civilians, women and children, and a lot of injured people, around more than 10,000 people who were injured. And that's very, very important to mention this, because the consequences of war is not just that people have been killed, which is really unfortunate, but also people are living with the consequences of war, with their injuries, with those who they lost from their closing families and environment, neighbors, and so on. More than 500,000 people were displaced during that war, and thus they had to live in open areas, in schools, in playgrounds, football pitches, and so on. Approximately more than 400,000 children needed psychological support. And as you may know also that there was a war just a few months ago that also has left lots of families, lost their families. And I know a family which has 25 from the same family, because a specific building was bombed, lost their lives. And the consequences, of course, are very, very hard. So I've done 4 longitudinal studies in Palestine. The first longitudinal study, I did it between 2006 to 2012, which was before and after the first war. In 2006, the original sample was around 1,100 children, which were randomly selected from all parts in the Gaza Strip. And then in the 2012, the follow-up study included 160 participants, which has, after 6 years from the original sample. And thus we have divided these participants into 4 groups. We collected data about post-traumatic stress disorder, and there were 4 groups: the resilient group, those who don't meet the PTSD criteria at both times. This is the blue color here: no PTSD at 2006 and no PTSD at 2012. And thus we called them resilient, because they were exposed to trauma at both times, but they didn't develop PTSD. And then in front of this, there is the acute group, which has been exposed to war trauma at time 1 and to trauma at time 2, and then developed PTSD at both times. And thus we called it the acute group, because they had PTSD at both times. And then the delayed group, they didn't have PTSD at 2006, but then developed it later on, 6 years later. We called it delayed group. And then the remitters, those who had PTSD at 2006, but not PTSD at 2012, and thus they were able to remit and cope with the PTSD and become later on without PTSD. And thus you can see here that the acute group is the highest group, with 67% of children who became adolescents later on, or adults, remained with PTSD, 67% of the sample. And then the delayed group as well, 21%. So if we take those who have stayed with PTSD, either over time or later on, delayed, these are around 88%. Remained with PTSD later on. While on the other hand, the remitters, the red here, and the resilient were 11% and 1%, only 1% resilient who didn't have PTSD and at both times, which is around 12% both with the remitters. And so you can see that this trauma causes them to stay with this PTSD or post-traumatic stress disorder for a long period of time. And we have looked at what causes the acute and delayed PTSD. What causes these? What are the predictors of the acute and delayed PTSD group in comparison to the resilient and remitted group? And we saw that, or we found that low psychosocial support from the environment of the child, like siblings, parents, neighborhood, relatives, low psychosocial support has predicted the acute and the delayed PTSD, as well as negative personalities, such as being anxious all the time, being fearful, and having some phobias, and the high number of traumas that they were exposed to, but also high repetition of traumas of the same traumas over time. And then the second study, we had collected data in 3 waves at September 2013, 10 months after the Second War, around 1,000 children aged 11 to 17. And then again, we collected data at 2014, immediately after the Third War. So the first phase was after the Second War, 10 months after the Second War. The second wave was immediately after the war, the Third War in 2014. And then in November 2014, we collected the data from the same participants 2 months after the counseling program. There was a counseling program intervention, which I will talk about it in a bit. 630 children has participated in this program, which we has followed up to see the effectiveness of this counseling psychosocial program. And we had the subsample in Al-Shuja'iyya. There was an area in the Gaza Strip which has been affected so much because it's closer to the borders of Israel. So we collected data from that area as well. We collected data about several things, including trait emotional intelligence, which is a questionnaire including 30 statements designed to measure global trait emotional intelligence, such as it's easy for me to talk about my feelings to other people. I often find it hard to see things from someone else's point of view. I'm a very motivated person. That was, of course, from a negative, we made it negative. I find it hard to control my feelings. My life is not enjoyable, and so on. So we measured here trait emotional intelligence. And then we also had parenting questionnaires. We asked 10 items about parental support to describe the parent's behavior with their children that enhances positive attributes such as self-esteem. Father often praises me, smiles at me, is able to make me feel better when I'm upset. And then psychological control of the parents to describe the parent's behavior, which could affect the emotional and psychological development of the child, such as love withdrawal, such as mother often interrupts me. They change the subject whenever I have something to say. So they control my psychological well-being and emotional, as well as my behavior. So this is about parenting. Again, we divided the children into 4 groups. The chronic acute group, those who have developed PTSD at both times or 3 times. And then the delayed, those who have developed PTSD later on. And the remitted, those who have been able to remit from the trauma and the PTSD. And then the resilient, those who didn't develop PTSD at all. And we looked again at predictors for this delayed and acute group. And we found that low educational levels for the mother and the father has predicted the acute and the delayed PTSD group. And also war trauma and non-war trauma, but also very importantly, low trait emotional intelligence has predicted acute and delayed PTSD. In addition to this, peri-trauma response and father psychological control, the parenting aspects, the negative parenting, has predicted acute and delayed PTSD. So we looked specifically at trait emotional intelligence because we found it a very strong predictor for PTSD over time, for the chronic group specifically. And we found out that emotional intelligence mediates the relationship between trauma and PTSD. And you can see here that trauma leads to PTSD significantly, is related to PTSD. However, when we put emotional intelligence in the middle, we can see that it is significantly mediating, which means that if the child is exposed to trauma, those who have low trait emotional intelligence are more likely to develop PTSD in comparison to those who have high emotional intelligence. Thus, emotional intelligence can be a protective factor. If the child is exposed to trauma and they have high emotional intelligence, this can protect them from developing PTSD, and it can protect them to be resilient, of course. The same thing with depression. We found that emotional intelligence, as it was done with a PTSD, the same thing mediates the relationship between trauma and depression. Those who have high emotional intelligence can be protected, even if they were exposed to trauma, they can be protected not to develop depression. Thus, exposure to violence can lead to psychopathology. However, we also looked whether violence in various situations, in addition to war trauma, political violence, the war trauma list of war traumas, whether they were exposed to violence at home by siblings and or parents, violence at school by peers, violence in the neighborhood. So thus they can be exposed to violence in one context, two contexts, or three or four contexts. So we want to see whether these various contexts of exposure to violence, whether this will lead to more behavioral and mental health problems. And you can see here that there's a cumulative effect. The more violence, the more contexts that they are exposed to violence, the more emotional and behavioral problems, the more depression, and the more PTSD. And you can see here 4 contexts in comparison to 3 contexts, to 2 contexts, and to 1 context of violence. Thus, the more contexts of violence, the more behavioral and psychopathology will be developed amongst children and adolescents. And as I mentioned, during the war, the 2014 war, lots of people were displaced to many areas, such as living with relatives, which is the big proportion here, 70%, but also living in with neighbors, around 6%, and in schools, 11% of people lived in schools. They rent houses, 9%, and some even in open areas. And as you can see here, those who were displaced were more likely to, well, let's say from our sample, there were 57% who were displaced from their houses because they were destroyed during the war. And thus we saw the differences between those who were displaced and those who were not displaced. And you could see here that they are more likely to develop PTSD, or let's say first, they were more likely to be exposed to personal trauma and other trauma and properties demolition in comparison to those who were not displaced. And also, they were more likely to develop PTSD. Both were highly, 62% and 50% to develop PTSD. Very high percentage from both populations. But even the displaced people were even higher than the non-displaced. We also looked at depression and functional impairment, and we found out that those who were displaced more likely to develop depression, and also functional impairments in the cognitive symptoms and the social symptoms. So those who were displaced were more likely to develop functional impairments. We then implemented an intervention after the 2014 war along with the Ministry of Education, who implemented an intervention with all schools in the Gaza Strip. And this intervention included various activities along 1 week. The first day included psychosocial support at the morning. Then there was a survey, and then storytelling activities from students and parents. And day 2, the activation of school out classes activities throughout, strengthening the religious and positive attitudes and values. There were free drawing activities, volunteering work in each class. And then in day 3, there were psychodrama activities. Parents actively participated in these activities, and then volunteer work activities with their teachers, parents, and social worker who visited injured children in the hospital. And then the day 4, there were open meetings for parents, teachers, and counselors and head teachers with the social workers, with various activities such as painting walls, poems, and in the final day, the conclusion of the activities with open day, including graphics drawn by children in classrooms, which had exhibitions were displayed, and children were given incentives due to their work. So we found out that this intervention, we implemented or collected data about PTSD before the intervention and after the intervention. And you can see here that PTSD diagnosis immediately at the first time was 53%, and then immediately after the war was 57%, and then after the intervention it has went down to 51%. It's still very high, but the intervention was significantly reducing the PTSD diagnosis. We also looked at symptoms, because sometimes diagnosis doesn't give you, it only gives you the clinical classification of yes or no, but we would like to look at symptoms always rather than just of clinical diagnosis. Even the symptoms has went down. The mean has significantly went down for after the intervention. We also looked at specific PTSD criteria or components, such as re-experiencing, avoidance, and the functional impairment, and which ones has been affected by the intervention. 2 things here, 2 messages. The first message is that it has affected some aspects in PTSD and reduced the effect between pre to post-intervention. Functional impairments has reduced. And the most important thing is that this has worked well with females, but not with males. So the intervention significantly worked with all the participants, but specifically with females, it was significant, but not for boys. And then the 4th study, which I have implemented, also collected data from Gaza and also in Qatar, because I wanted to compare Middle Eastern children who are living in unstable environment in comparison to stable environment, as well as we collected data from Syrian refugees. This was in September 2016. We measured several things: trauma, PTSD. We collected data from parents and children, behavioral and emotional problems, depression, resiliency, psychosomatic, parent and sibling relationship, trait emotional intelligence, brain trauma, injury, parenting, and so on. And we also implemented CBT, cognitive behavioral therapy, with those who have developed PTSD. And thus we collected data before, immediately after the CBT intervention, and 3 months after the intervention, just to see the short-term effectiveness as well as the long-term effectiveness. We collected data from children, from parents, from teachers, and also because we are still analyzing the data, so I will not show all of the results. We also collected saliva samples from those who have PTSD and their parents and their siblings. We extracted DNA to investigate around 950,000 SNPs and the imputation and family genetic analysis. So there were around 2,800 Qatari children, around 1,000 children in the Gaza Strip, and around 500 children from Syria. Again, we collected this data along 2 phases, but also implemented an intervention with those who have PTSD, as I said, and then immediately after the intervention and 3 months after the intervention. And you can see here that the PTSD was the highest amongst the Syrian sample, and then the Gaza, and then the Qatari sample. I will talk about this later on, about the differences. But you can see here, even in Qatar, there were children who were exposed to non-war trauma. Thus, they developed some PTSD. But if you can see here, the Syrian refugees and the children and the adolescents in Gaza had the highest PTSD. Again, we collected data about peri-trauma response. What is the response of the child or the adolescent when they were exposed to the trauma? At the time of the trauma, what they thought about. So the questionnaire asked, I thought I would die. I was trembling or shaking. My heart was beating fast. I was nervous or afraid. It made me jump, and so on. So the reaction during the trauma itself. And thus we found, again, we did mediation analysis. Trauma significantly led to PTSD, post-traumatic stress disorder. However, it was mediated again by emotional intelligence. Again, so with this 3 samples amongst Syrians, amongst Qataris, amongst children in the Gaza Strip, the same pattern, that emotional intelligence mediated the relationship between trauma and PTSD. And thus those who have high emotional intelligence can be protected. Even if they were exposed to trauma, they can be protected from developing PTSD. The same thing with peri-trauma response. Those who have high peri-trauma response are more likely to develop PTSD. And those who have less resilience, they were more likely to develop PTSD. Same thing or same pattern was found in the Gaza sample. And as I said, in Qatar as well as in Syria. And thus it means that it doesn't matter what trauma the child was exposed to, whether it's non-war or war trauma, the mediation variables can be the same, because emotional intelligence and peri-trauma and even parenting, we did some analysis with parenting, can protect the child from developing psychopathology problems. And then we looked at the effectiveness of cognitive behavioral therapy along the 3 times. And you can see here that CBT was effective so for example, in the Gaza Strip, 57% reduced to 22% amongst those who have PTSD. And then the same thing in Qatar, those who have PTSD reduced significantly. The least which was reduced was amongst Syrian, although it was significant, but it was the least amongst Syrian refugees. Also, we looked at the long-term effectiveness of CBT, and you can see here that it's still significantly different from the baseline, which is before the intervention, but it went a bit higher than immediately after the intervention. And this is because a war has happened at that time when we were implementing the intervention. A new war has happened in the Gaza Strip, and this has affected the children. But still, the figure is significantly lower than before the intervention. As I mentioned, the war has happened at that period of time, and thus this has increased. Thus, there is in Palestine a long-term conflict, and many studies were performed in Palestine. So we thought that we maybe can do a meta-analysis to collect all studies that were done in Palestine since, let's say, the first Intifada, 1987 until now, to see what can be done for the next steps and as well as for the interventions. So we found around 90 articles when we searched all search engines with specific terms about PTSD, trauma, and so on. And we reached that to the conclusion that there were 90 articles included in the review, 17 with children and adolescents, and 15 with adults. 41 studies included PTSD prevalence. There were 8 studies during the first Intifada, 24 studies during the second Intifada, and 9 studies after the first war and the second wars. And you can see the cumulative effect of the conflict on PTSD. So during the first Intifada, the prevalence of PTSD was around 32%, and then it increased in the second Intifada to 39.6%, and then after the first war, 42%, and then to 53% after the second war. And you can see the cumulative effect of the conflict over time, that more people will be exposed to PTSD. In the meta-analysis, we looked also at interventions and risk factors and coping, but I will not show these results here. Now I will talk about the journey of children, of refugee children. And you know that refugee children are, or let's say people who are forced to flee their homes as a result of war or political violence. There are nearly 50 million children who have been uprooted across the globe, and 28 million of them driven from their homes by conflicts not of their making. And millions are migrating as well in the hope of finding better and safer life for themselves and their children. Children now make up more than half of the world refugees, despite the fact that they account for less than a third of the global population. So they are a third of the global population. However, they are more than half of the world's refugees are children. And all of us know this picture of that child. And actually the British Somali poet, Warsan Shire, has explained this in a very sad way, but beautifully as well. No one leaves home unless home is the mouth of a shark. You only run for the border when you see your whole city running as well. No one puts children in a boat unless the water is safer than the land. Children, refugee children, are exposed to war trauma in their home country. They witness or being subjected to a series of traumatic events. They witness or being forced to participate in violence, even in some cases. They have multiple losses, the death of their relatives, their parents, their siblings, their neighbors, and so on. They are deprived of basic human rights and even some infrastructures like schools, water, food, safety, and so on. And then the process of migration itself, difficult and dangerous journey to the country of asylum, having to cross dangerous routes and roads and sea, face further conflict maybe even during their journey, and sometimes rely on human traffickers and smugglers. And then they have also to cope with the lack of resources later on. And then post-displacement, they have to adjust to a new society and culture, and thus they will face culture bereavement. They have to adjust to a new foreign place, to find somewhere to live and to study, to the school. The language is very new to them. The culture and everything is very new. They may be also deprived from money and support. They have to understand and adapt to the socio-cultural, political, and legal framework. There are lots of paperwork that has to be filled in a foreign language as well, because they are refugees and so on. Adjust to new schooling and educational system. And after resettlement, even if they have then a house and they start to study the language and so on, they will still feel disorientated, the sadness, the anger, the guilt. They will have concentration difficulties, learning difficulties, the disruptive behavior and depression. These are the consequences of going through all of this journey from home to refuge. And there is also a lack of educational progress later on. And still, you can see the leaders of the world who are supposed to be a modern world, saying our country would be overwhelmed if it opened its doors to every refugee. They do troubles in these countries, and they don't want to accept these refugees in their own countries. Some leaders also say, some try to break into our country as if they are thieves. Other leaders said, the flow of people across the Mediterranean towards our country is a swarm. And you may have seen this picture of these Syrian refugees, children who are trying to warm themselves around the fire in the refugee camp in Greece. That's a picture in 2019. So it's not a long time ago, it's just 2 years ago, imagine this. And still happening nowadays. The first study I conducted with refugee children amongst in the UK, I compared them also to UK children. So we had around 120 British-born children from 6 to 10 from 7 primary schools, and then 150 children, refugees from 6 to 16 years old. We collected this from 2 charities. The refugees were from different countries in the world, from Afghanistan, African countries, and so on. And we found that refugee children, in comparison to UK home children, are more likely to have peer problems in their schools in comparison to home children. So more than 45% are in the clinical range of peer problems. They have also functional impairments due to PTSD in comparison to British home children, more than 30% in comparison to that's very significant. But also they are also facing physical health problems, as well as psychosomatic problems, such as sleeping problems. They have appetite problems and so on. So they are more likely to face this significantly more than the home UK children. So we looked at the effect of friendship quality, and we found out that friendship quality in their schools can protect them from developing peer problems and functional impairments and psychosomatic problems. And thus those who have established friendship and their friendship was on a good quality, this can protect them from developing some of the psychological problems. If they are less bullied, less victimized by their peers, by their siblings, this can also protect them from developing psychosomatic problems. However, physical health problems was not explained by any of our moderators that we included in the study. And thus, this may need to be put into account and the importance of it because of the health awareness amongst refugee children. And maybe they don't know the new system about the health system in the new country. And then the second study I did amongst adult refugees versus home in the UK, there were around 152 refugees who came to the UK as refugees before the age of 18. And the mean age was 24. And then I had collected data from 148 British-born participants where the mean age was 25. The same thing amongst adult refugees even, in comparison to home British adults. The refugee adults have more likely to develop PTSD, are also more likely to develop depression in comparison to home adults. They are less likely or lower life satisfaction amongst refugee adults and also lower psychological well-being. Good friendship minimize the differences between refugees and home children. Again, in this study, we found that good friendship and more years spent in the UK has helped the refugees to adapt better and increase their life satisfaction as well as their psychological well-being. And then we investigated the effectiveness of various interventions amongst refugees. There were several charities that we collected data from. That's the third study that I will show. There was a specific charity that specialized in sport. The intervention that they used to do with refugees is specifically sport. The second charity was specialized in creative expression. The third charity was specializing in mentoring schemes, such as Big Brother, Big Sister scheme. And then the fourth charity was specializing in education, and the fifth one in social activities. We collected data from 80 refugees, and we compared them to 80 controlled British and American children. And we found out that those who participated in sports intervention, so we investigated the differences between refugees who participated in interventions in comparison to those who didn't participate in these interventions. And we found out that refugees who participated in sport intervention, this has helped them to increase their life satisfaction. The same thing with educational intervention. It has helped them to increase their life satisfaction in comparison to those who are refugees, but didn't participate in that intervention. The mentoring scheme, Big Brother, Big Sister scheme, has helped the refugees to reduce their conduct problems. And social activities interventions has reduced their emotional problems and increased their self-esteem. And thus, these specific interventions such as sport, educational, mentoring, and social can help in specific psychopathological problems. So we need to take this into account for each specific psychopathology problems or psychological problems or life satisfaction needs specific intervention to be tailored to these refugees. I will talk a little bit now about mental health services in the Middle East specifically and in war zones. Although some national healthcare plans have started to recognize mental health care as essential, such as those in Iraq and Palestine, many Middle Eastern countries, I will show in a figure now, tend to lack mental health funding, resources, and workforce. And thus, psychological service providers face a lack of qualified and specialized staff, financial constraints, political conflict, poor community awareness, because some people think that going to a mental health service is a stigma, and thus they don't want to go there and be recognized as someone who is receiving mental health support. A study in the West Bank has found, for example, that there is a poor community in Palestine, a poor community awareness about these issues. And you can see in this figure, the global mental health workforce. This is the rate per 100,000 population in Middle Eastern countries with continuous conflict compared with high income countries and global rate. And you can see, for example, the global rate for several mental health as well as social workers. So you can see psychologists, social workers, other paid mental health workers, mental health users, child psychiatrists, and psychiatrists in general. The global numbers are high in comparison to the Middle Eastern countries. And you can see here in Iraq, the numbers are so low. In Libya, there is none, 0. In Yemen, very, very low. And you can see here, for example, let's say psychiatrists, for every 100,000, the population, for every 100,000, there is less than 1 psychiatrist, less than 1 mental health nurse, around 2 psychologists, and less than 1 mental health nurse or child psychiatrist. There's no child psychiatrists, or there's less than 1 social worker. A bit higher for Syria, but still very low. But when you compare it with the high income countries, so we're talking here about the numbers here up to 6 for the global, and then less than 2 for Iraq, 0 for Yemen, less than 1 for Yemen, 0 for Libya, less than 1 for Yemen, and less than 3 for Syria. But for the high income countries, you can see here can reaches to 60s. So the situation in the Middle East in comparison to the global is very bad. And in comparison to the high income countries, it's even worse with regards to the number of mental health workforce. And you can see that's shown in our study recently in the British Medical Journal. And thus rates of mental health problems are much higher in Middle Eastern countries. But if we speak about Yemen in specifically, it is much higher in Yemen than other countries in conflict because of the war, the floods, the epidemics, poverty, and water shortages, which has damaged the healthcare and education system. And thus there is a lack of practitioners. An intervention, so for example, that was done amongst general practitioners, GPs, was found to improve their performance in the emergency management of acute medical problems in Yemen. And the WHO Mental Health Gap Action Program subsequently trained health and community workers to increase access to mental health services. However, these services have not been evaluated for use and effectiveness. There was no specific study that has evaluated the effectiveness and use of these services. And thus we have to come to rethink about trauma and resilience in the context of political violence. We have to think about new directions in research and practice, because children in war and refugees are in great need of psychosocial support and help. War and refugee situations are cumulative effects that affect psychological well-being even into adulthood periods. Exposure to violence in multiple contexts can affect psychological well-being, and thus resilience has been affected hugely in continuous traumas areas. We found out that trait emotional intelligence, spirit trauma, parenting, friendship can all help to reduce the effects of trauma on psychopathological problems. And thus we need to include these aspects into interventions and therapeutical approaches: parenting, friendship, birth trauma, and emotional intelligence. Interventions are important to reduce the effect of war. And also intervention programs should be targeted and tailored to high-risk groups of children, especially in war, because you don't have enough resources, and thus we have to take the highest risk groups. Parents should be included in the counseling programs. There should be different activities as well, as we showed: support, education, social activities. We are all stuck with the CBT only, cognitive behavioral therapy, but there are other things that can help different aspects, because we shouldn't only focus on one psychological problem such as PTSD or depression. There are other aspects such as peer problems, conduct problems, and so on. And thus we have also to think about new directions in research and practice. There is a need for suitable instruments for ongoing trauma and ongoing PTSD. The Western tools or instruments for trauma and PTSD may not capture the real situation of war zones for children and adolescents as well as adults. So we need to develop new instruments to be able to tailor them to the situation in these war zones. But also we need to also have innovative ways of treatments and interventions using the technology for ongoing wars and traumas, because in a war situation, you cannot have a psychologist for each child or for each 10 children. You have thousands, millions of children, adolescents, and adults, and even the practitioners themselves, the psychologists themselves, are exposed to war trauma, and thus they are in need of help and treatment or intervention. And thus we have to have innovative ways. I will speak briefly about this virtual reality project that I'm working on now to help children and adolescents in war zones as well as refugees. Meta-analysis studies found that all virtual reality therapies, which was specifically exposure therapy, were done amongst adults and specifically military soldiers. And thus they are not tailored to children and adolescents, but also not tailored to children in the Middle East, because these therapies are designed with the idea of that countries that the soldiers were deployed to were themselves the threat for them. Since these are the countries that the targeted study children are living in, this is not a suitable context for therapy for children who are in the Middle East, for example. And those also, these are in English, there is none in Arabic. Virtual reality therapy can be used to treat traumatized children at any place, at any time, with less resources as well. You don't need a psychologist. And thus we thought about developing this. I will talk a little bit just about online CBT training, which was done in Iraq, which has proved very effective. So patients and trained therapists in Iraq and the Middle East and Europe communicated through structured writing assignments submitted online. And this form of intervention could improve PTSD, anxiety, depressive mood, and grief across different cultures. We started to develop this intervention, virtual reality intervention, to include several sessions, psychoeducation, where we increase the awareness of traumatized children about the trauma, why they feel different after the exposure of trauma, to teach them the emotions, anger, sadness, frustration, because children at that stage, they don't understand the differences between emotions. And thus we are integrating storytelling about these issues. Relaxing techniques such as deep breathing and muscle relaxation, safe space, songs, and so on. Adventure, problem solving techniques through games with challenges and exercises, exposure therapy with the attention bias modification therapy, and resilience techniques. We integrate storytelling, as I said, modeling. The practitioners does something and the child will imitate the breathing and the challenge. There's also art and play therapy. The child will draw a beloved character, for example, to the child, who will then can interact with the child saying, thank you for drawing me with nice colors. Let's play together a game. And then they will develop a relationship to do some adventures in a game with challenges that are designed with a specific environment where the child will face these challenges, such as grinding or climbing a mountain, being in a ship in the sea, and the need to reach the beach with lots of challenges. Now we are implementing this, we're building this to implement it in the Gaza Strip with 30 children. So hopefully this will bring some good results. The idea here is really, when we face thousands and millions of children, you don't have specific practitioner or psychologist for each child, and thus virtual reality can solve the problem in these situations. I come back just to conclude to the ecological perspective. Again, the child is in the middle, but they are affected by their school peers, by their siblings, by their family, by the culture they are going to. If they are refugees, they are going to a new country, the neighborhood, but also the political situation. We are living in the context of political violence. I will just show you a very quick video to show you how much the political violence or the political context affects.
Let me ask you a question about Iran, since that's our first thing. Right. Whose team are we on in the Middle East? Because I know, so we're fighting with Iraqis to defeat ISIS, along with Iran. But in Yemen, we're fighting Iran with Iraqis and Saudis. That's not quite right, but that's okay. Whose team are? Look, here's who are we bombing? Let me ask you.
And then later on, also Tony Blair apologized for mistakes over Iraq war and admits elements of truth to view that invasion helped rise of ISIS. So the political situation is also should be taken into account. We are not living in a when we want to treat children, as I showed you in one of the interventions that we did. The war has happened suddenly, and thus some of our results were disrupted. Thus, we came up with this idea of virtual reality to help immediate problems. I will finish with this story just to show you also that we have to have to look at the history, as I showed at the beginning of my talk. The history is very, very important, and sometimes history repeats itself. I will show you a story of Ahmed, 12 years old from Damascus in Syria, and Harry, who is 92 years old from Berlin, Germany, who has survived the World War II. Despite being separated by over 70 years, the two stories contain many similarities. And thus, I will show you this similarities in a moment. But I want to say also that we have to have, because I will finish with the video, we have to have an individual commitment. We have to have a professional commitment, research and academic commitment to be able to help these children, to raise the issues of children in war zones as well as refugees. And I mentioned the political situation and the political context because we cannot take out research, professional, academic, without the context of politics. And thus we have to campaign as well politically to stop the war everywhere and help the refugees everywhere in the world. I will finish with this video, the similarities between the child in Syria and the one who survived the war, the World War II.
It was a happy childhood, but I could feel what was happening around me. One morning I woke up, the shops had been ransacked, all the windows were smashed, and my school had been burned.
الصوت كان كتير عالي، كل البيت كان عم يهز، كان كتير قريب الصوت، الناس كانت عم تصرخ وتركض، فكتير عالم انقتلت وماتت.
My mother said I had to go. I didn't want to leave her. But she said we would meet again soon. She must have known that she would never see me again.
كان قرار إنه موت ولا عيش. أنا وأخوي هربنا لحالنا، نمنا بالشارع، بالبساتين، بالحدائق، وين ما يصح لنا.
They brought us to a refugee camp. We had hardly any food.
الرجال كانوا حاطيننا بقارب صغير، كان لشخصين أو 3، بس نحنا كنا 12، بأي لحظة كان ممكن يقلب.
Planes flew over us and gunned our boat. I dived and hid under a raft.
كان كتير عتم، ما قدرت لاقي أخوي، بلش صرخ بشار بشار.
I've never been more scared in my whole life. I thought I was going to die.
قضينا 10 أيام بالماء.
I thought about my family the whole time.
أكثر شيء اشتقت له هو أمي.
We were waiting to know our fate. Well, thankfully, they let us in.
كنا كتير مبسوطين لما وصلنا آخر شيء.
I am alive.
أنا عايش، أنا
I
واحد
am one
من
of the
المحظوظين.
lucky ones.
Thank you so much for listening. I appreciate your patience. And if you have any questions, I'm happy to listen to your questions and answer them. And if you want to email me, this is my email. Thank you so much.
Right. Thank you so much, Dr. Samara, Prof. Samara, or Prof. Muthanna. It is very emotional. I don't know how people feel about it, but it's really difficult even to hear those stories and to see those numbers and the studies. It is very sad, unfortunately. But thank you so much for just bringing this as numbers, as facts, to know like the side of the crisis that people are dealing with. And it's not an easy task, but also you made it clear that things could be done. it's not hopeless. We can do things to help children and to help families, which is really important, and that's why we are here today. So thank you so much. I think there are many questions. I have many questions. I don't think we have time for all those questions, but thanks for sharing your email. I'm sure we could communicate, we could get in touch to see how we can help in any way. Your work is really good. Not good, it's excellent. And it is an honor to see this work today. So we'll go straight to the question, because we know that Dr. Fawzi is with us now, so we can have questions for her as well. We'll try to get the questions, and apologies if I miss any of the question that was.
Can I stop sharing the screen, maybe?
Yeah, please. Yeah, if we can stop sharing the screen. Yeah. Right. So. So one of the questions was, thanks, Prof. What is the important thing that you can advise to implement from your studies in Yemen?
Yes, as I showed some figures in Yemen, as well as the health services, not just in Yemen but also in the Middle East, are very, very bad and very low in numbers, and thus we don't have enough health services for each child or for each adolescent specifically, that we have so many numbers. But as I said, we need to tailor our efforts into the situation. Firstly, we have to take into account these factors that can protect children. So we can do, instead of doing individual interventions, we have to do group and school interventions. As I showed, the intervention in the Gaza Strip that we did in schools, it was for the whole school. So you can target the whole school at the same time with 500 or 600 children with psychosocial activities. I can, if anyone wants the study, we have already published that study. So this can be implemented with schools at the same time. And we have shown that this can be effective in treating children. Also, tailoring different activities such as sport activities, social activities. These doesn't really need practitioners. Yes, there are some aspects that need to be added to these activities, sport, social, mentoring schemes. There are little maybe training for these activities. They don't need a specialized practitioner or specialized psychologist. Sport, social activities, educational activities. What else did I show? Mentoring schemes, the big brother, big sister schemes. So these can help in various aspects. The third thing is the aspects that I talked about as protective aspects, such as emotional intelligence, parenting, peer support, and friendship. These can be protective factors, and thus we maybe want to encourage these schemes in schools, in community, in families. So we can do training for families, for parents, for siblings, for peers, on how to do the peer support, the parenting support, and to protect these children from developing further problems. And also with our study now, I hope that this will reach, and we will develop this virtual reality. I'm very enthusiastic about it and very keen to finish it. We have got a small grant to develop a pilot study. Hopefully, if it is successful, then we can have this virtual reality being implemented at the same time with thousands and millions of children at the same time without the need of practitioner. I know it's not an ideal intervention, because you have to have an interaction with the practitioner. But we, in situations where we don't have enough practitioners, these few practitioners can utilize this virtual reality and implement this intervention with the children and adolescents, and in the correct proper language as well, which is suitable to these children.
Thank you so much. And another question was about, I think that might go for Dr. Shakil Ahmed. Do you see self-harm mainly in children with depression and anxiety, or do you see it in, I don't know, it says internal or any other reasons for the self-harm?
Assalamu alaikum.
Alaikum.
And Jazakallah, Professor Samar, it was really painful just to watch through, just to listen to your presentation, and I think, and we're not even living in that. This is just the numbers, and but also the challenges of we're not talking about 10 or 100 or even 1,000 children to one therapist. We're talking, I don't know, tens of thousands or probably millions to one, and I think it just highlights, and I briefly mentioned in my presentation that actually we're way in Yemen, you are way beyond guidelines and research. None of this applies to you in Yemen because the situation is not stable. All these things are done in stable countries, where you have resources, etc. And so you don't so there probably isn't any such thing as a pure depression over there. There'll be very high rates of trauma, for example, PTSD, and I think your slides, your research has shown some of that. And I think it's really important to think about children, especially, but every patient, but particularly children, in a whole context. Because I think this is the brilliant thing about working with children. They're not alone. A bit like adults. Unlike adults, they have people and systems around them that are supposed to protect them and help them nurture and develop. So you start with the parents and siblings and grandparents and uncles, aunties, schools, neighbors, all those things. And when we have hardly any resources, we have to use those systems to to help treat them. And I think this is the key thing. So I mean, we do that even here, and we try to do it even here in UK. But I think in Yemen or other countries where there's lots of conflict and unstable political and economic situation, I don't think you have any choice but to use other systems that are around the child, and use parents as co-therapists. Use schools, use imams, use whoever you can find in the community, to use them as part of the treatment plan. I think a question about self-harm particularly, I mean, here we would see self-harm not just in anxiety and depression. You see in a variety of reasons, and sometimes there won't necessarily be any mental health diagnosable condition attached to why people self-harm. And I think it depends on the religion and culture. So I think you probably can't apply what we see in many in UK in terms of self-harm to, say, Arab countries or many other Muslim countries. I think culturally they're so different, and also from religious point of view, that it's very difficult to interpret that. And you could be very severely depressed without self-harming, or we would see a lot of people who would come to A&E hospitals with recurrent self-harms and overdoses, who are not depressed because they have personality disorder, for example, or some other stressors. I think self-harm just shows lack of coping strategies to deal with a stress or number of stressors. That's what that shows. It doesn't mean that there's a particular diagnosis attached to it. We still have to assess for that separately. So I hope that answers the question. It's I guess the way to think about self-harm is it's just a symptom. It's not a diagnosis. So there isn't any particular treatment for that symptom. You have to figure out what's driving it. Where's the engine in this car that's leading to self-harm? And then you have to cut off the engine or treat that engine.
Yeah, thank you so much. Prof. Muthanna, we have got 3 questions, just make them together. So the first question, your study about teaching, the school study about training people, did you train psychologists or teachers? Then the second question is, do you think there could be any training program, because training psychologists to do work will take ages and people can't wait all this time at Yemen and those countries. Is there any training program that would take shorter time period that would make it a bit practical to come with some like therapists or counselors or anyone. And the third question is, we hope you could come to Yemen at one day to see things there and apply some of your projects there. So those were the three main things.
Thank you so much. First of all, with regards to the study in schools, no, we didn't train the teachers. There were some psychologists and social workers who did go to the schools and gave general instructions. So there were written instructions about each day, and that was very brief, really. So there were easy activities. And that's what I meant when I answered the first question before, is that we don't have to do complicated things such as CBT and trained practitioners, especially when we have war zone and a lot of trauma, and then even during the intervention itself, another war could happen. Thus, we have to rely on simple things that could help a lot with these children, because little can help in these situations. As I said, drawing, poems, art therapy, and play therapy, very simple activities. Yes, there were some workshops, but not intensive workshops that teaches them on how to implement CBT. No, it's just instructions on how to, what to do on the first day, what to do on the second day, what to do on the third day, with the help of a psychologist, or let's say the advice or the instructions of the psychologist and the social worker. So you can see this in our paper, the details of each day. And thus, these were very simple, instructions and intervention. I hope this answers the question.
Do you think this could be applied in Yemen? So our colleagues who are presenting today, if they look at the paper, would they come with like a project that they can start applying?
Yes, definitely. As I said, we have to take, in very difficult situations, we have to do simple things rather than to wait until we train 1,000 psychologists or practitioners to implement CBT because CBT, it's 8 or 10 sessions, and in each session you have to do something, and then each session takes a week, and then in the next week we have the second session. It takes so much time and so much effort. I'm not saying that it's not effective. It's one of the most effective interventions, of course. But in situations like Yemen and Palestine, and when there's an ongoing war, we have to find quick solutions such as this: the psychosocial intervention in the school, sport intervention, social activities, mentoring schemes, peer support, friendship quality, to increase the friendship quality, maybe to train parents on how to deal with their children in these situations as well, and thus turning the parents themselves to practitioners. So that's very, very important. The second question about, I think I can see it, psychologists take many years to get trained. There are not enough trained workers at all. You mentioned this, so you advise, is it practical and useful to do intensive short training for mental health workers? Yes, it is effective, and it has. I showed this in Iraq, for example. They have implemented this CBT online, where they have Iraqis who are living in the West, as well as Western practitioners who have helped practitioners in Iraq to implement this CBT with ongoing support, advice online. So I can also give you this. I mean, it's in my talk, that study, which showed that it was effective. But also, yes, doing, taking advantage of the technology. Yes, CBT can be done online, training practitioners on how to do CBT, because we have to take an advantage of the technology. This can take maybe a week of training to do the CBT, because you have to have some background of it. And then in the training, this will give you the skills and the techniques on how to implement it. And I refer here to trauma-focused CBT rather than just CBT in general. but a trauma-focused CBT. And I hope, yes, for the third question, I hope that I will come to Yemen. I've never been there, but I'm really keen to visit Yemen. I'm happy to collaborate with anyone who is in Yemen and wants any help with regards to the practice side or the research side and want to collaborate on this. I'm happy to really collaborate on this. And maybe if you want to suggest that I would do like a small course, a short workshop for anything related to the practical things or the research, I'm open to suggestions.
Thank you so much. Then I've got a question about that very interesting study about the effect of the therapy you provided, and the graph that showed children from Syrian refugees didn't show much improvement in comparison with the Palestinians and the third, I can't remember it now.
Yes.
But was there any explanation? Qatar one. Was there any explanation for this?
Very good question. Yes, I wanted to talk about it, but then I forgot. Yes, the Syrians is a very intensive war, which has caused a lot of destruction to the country, but also to the people. There's a continuous, intensive, repetitive trauma. It happened in Palestine as well, but there's a long conflict in Palestine that has taught children, adolescents, and adults in Palestine to develop some coping skills over time, some resilient techniques. So they developed this over time with the conflict. They learned how to cope with things. They learned how to develop emotional intelligence. They learned how to cope with difficult situations. And thus has shown in Syria, which is more recent as well as more continuous in comparison to Palestine as well. It is, yes, it's a continuous conflict in Palestine, but you know, the war happens and then it stops. And the second reason, so the first reason is that Palestinians maybe has developed, I'm just speculating here, that has developed coping skills and techniques and resilience over time with the long-term conflict. The second reason is that there are established centers in Palestine, and you can imagine that the Gaza Strip is seized and so on, but there are lots of resources there and measurements of mental health services. There's a specific center, for example, in the Gaza Strip, the Center for Mental Health Therapy, that deals with all mental health problems. Also, the Islamic University in the Gaza Strip, they have a specific center for themselves. So the services in Palestine, because of the long conflict, has taught them to develop these services over time as well. In comparison to the Syrians, it's not developed well there. Thirdly, in my sample, I talked about refugees. And refugees, in addition to the war trauma, they have faced further traumas during their move from their country, as I showed in my presentation, from the war situation to the way to the country that they are going to. And then in the new country, they face further traumas with the adaptation to the new culture, to the new language, to the new system, and thus they develop further problems as well.
Yeah, thank you so much. I don't have any other questions unless anyone have got any questions. And just,
I think there's a question there about research ethics.
Yeah.
Someone asked. Yes, we always apply for ethical approval. So I apply it through University of Kingston University, London, and also whether we go to a specific country, we also apply for ethics inside that country, whether it's a hospital or a university or a service center. We also have consents from the parents if the children are below 18 years of old, and the assent of the children. So when we go to collect the data, we ask the children to assent as well. So we have ethical approval that we apply for, and then consent from the parents, but also the consent of the children themselves. And we ask them whether they feel comfortable to participate in our study, They can stop at any point if they want, and so on. So we take into account these ethical issues, yes.
Right. I think we've got a few more questions now. I'm not sure if Professor Fawzia, Dr. Fawzia is with us now, or because she was and then I think disconnected. So I'll take this question for Dr. Shakil Ahmed. Depression, because we don't have enough psychiatrists and psychologists, what is your opinion about giving medication to young children and teenagers, such as SSRI? I know it's not perfect, but is it better than leaving them suffering?
Yeah, that's a really interesting question, and I guess you might find it really ridiculous to compare this to UK, but this question, we deal with this here in UK as well. Don't have access, somebody doesn't have access to CBT, for example, or a therapy. There's a long waiting list. Okay, do we start medication in them while they're waiting or not? And I think with the places with conflict, this will be much more acute. I mean, how many children will you treat? You'll just start everyone on antidepressant because there is no therapist, or there's maybe one for every 10,000 children. And I guess if it's effective, then you would think, okay, well, you can get some of these antidepressants are quite cheap, fluoxetine, sertraline, etc. What's the harm? But I guess there's two aspects to that. So the first one is it won't work unless it is depression. And also, even then, it won't work if it depends what are the perpetuating factors. So on the one hand, you're trying to treat a set of symptoms or condition called depression. But on the other hand, if there are lots of factors making that child or young person ill, so for example, ongoing war or ongoing trauma or some other issues, it doesn't matter what treatment you offer, unless you get rid of that perpetuating factor, they won't recover. So you could give them antidepressant, but unless you know what is stopping them recovering, it won't work. So that intervention on its own won't work. But also equally, there's some suggestion to say that I'm not sure whether there's any latest research on this in children, especially in non-Western countries, that if they don't have biological symptoms of depression, for example, changes to appetite, activity levels, diurnal variation in mood and sleep, etc., then it might not work. It might not be as effective, antidepressants in any case. So yes, if you find somebody who's severely depressed with all the symptoms, then yes, antidepressant would work, even if there's no therapy or whilst they're waiting for therapy. And actually, we do that here as well. But if you're not sure about the diagnosis, you're not sure about perpetuating factors, then it might be more harmful to give antidepressants than just give them that. But on the other hand, you also have to think about potential side effects and who's going to monitor them. So because we know antidepressants can cause symptoms such as increasing suicidal thoughts or new onset suicidal thoughts, but also lots of other symptoms, but also it can cause withdrawal effects if somebody stops suddenly. So if you start antidepressants, somebody needs to monitor it. Is it working? Is it not working? Is it giving side effects? Is it giving suicidal thoughts? And then they need to be changed. So if you can't monitor, then it's best not to start medication. So I guess the short answer would be no. I don't think anyone would recommend just starting medication for lots of children potentially with depression in the absence of therapy. But yes, in some cases you could do that, provided all those other things that I mentioned are covered.
Okay, thank you so much. Another question for Professor Muthanna, and I thought about this. EMDR, we see here in practice in the UK that especially children from refugee camps usually benefit more from EMDR because of the language barrier when you compare it with trauma-focused CBT. But we haven't heard you talking about EMDR, and the question is it useful in anxiety and PTSD, and whether it could be used?
Yes, we did Yeah, in the CBT intervention that we implemented and amongst Syrian refugees as well as Qatari and the Gaza Strip, we integrated EMDR and the CBT itself. So it was part of the sessions. One of the sessions we implemented EMDR, and it's very, very effective. And some meta-analysis has shown that EMDR is one of the effective. The most effective one is the CBT, which is the whole 8 or 10 sessions, but it is very intensive and it takes time, resources, and money. But EMDR is very brief, very short, and very effective as well. Yes, it does help with anxiety problems, with PTSD and depression. The only problem is that the practitioner needs to discuss a few things with the patient as well. So it's very, very important that the practitioner is from the same culture as well as the same language as the patient, the child, the adolescent, or the adult, because there's some sort of interaction with the practitioner with the EMDR. But yes, it's very effective and very useful and very short in comparison to other interventions. So if there's any possibility that anyone can do EMDR, training, that is effective as well.
So
could I ask is it okay if I ask a question? It's actually on the question and answer, and I'm really interested in this. Is that okay, Mohammed?
Of course,
yeah. So it's well, let me see if I can find the exact question. Did you see a difference in children with PTSD between the village and city, but also between boys and girls?
Yes. As I said, more in other research, we found that girls are more likely to have internalizing problems, emotional problems, depression, and so on. And while boys are more likely to have externalizing problems, such as conduct problems, behavioral problems, ADHD, and so on. However, girls are more likely to cope. And like, for example, in the psychosocial intervention, we found that girls benefited more than boys in that sense. So they are able to adapt to situations and to interact with the intervention, but also to have better results than boys. What was your second question? I think that you asked about girls, gender, and
villages and cities.
Oh, villages and cities. Yes, there were some contradicting findings really with regards to differences between villages and cities, but also between refugee camps inside the same country. So, for example, in the Gaza Strip, there are refugee camps, and there are people who are living in the city, and there are people who are living in the village. So there are contradicting findings. Some studies do find differences, but some other studies, they didn't find any differences because the trauma is trauma and all are exposed to traumas. It depends on how much support they get from their parents, from the services, and from the neighborhood, from the peers and the schools. It is this is the thing that can determine how much they can develop more problems or less problems, as well as some of the individual characteristics, such as emotional intelligence, that we found in our study that can help. And thus maybe we can take into account these when we develop further future interventions, to take into account the parents, but also the individual characteristics, to improve emotional intelligence, to improve how parents can deal with these problems, and also do some maybe interventions with peers and siblings. I hope I answered your question.
Yes, that helps. So sounds like we need probably a bit more research on the village versus city, but also there's a complexity with the refugees versus non-refugees, because that complicates the picture even more.
Yes.
Doesn't it?
Yes.
And I think there's just coming back to one of the points you made earlier on, and I think somebody's raised in the questions, is about how do you address the resource issue. And I think sometimes as healthcare professionals, and definitely as a doctors, we get really, I think, tunnel visioned in thinking about formal training structures, which is obviously really important in terms of quality maintenance, etc. But when you're beyond that situation where you have 1,000,000 to 1 in terms of therapists, etc., I think that's never going to solve the issue. And I think we have to think outside the box. And it just reminded me of one of the examples, which isn't mental health, and it's not from Yemen. So I know in Pakistan, we have a relative, and he's a surgeon, and he told me that he's trained one of his receptionists who can't even read and write to do appendectomy. Yeah. And you know, so he's not a doctor, he can't even read and write, he hasn't even been to school, and he can do appendectomy under supervision. So he can supervise him, do the surgery. So this is how you could scale up. And in terms of mental health, there is no reason why you couldn't train non-mental health personnel into simple interventions, you know, a bit like you mentioned. And I think that has to be part of the solution, because there is just no way you could ever meet the need, especially if there's ongoing war.
It's very, very good point. Thank you so much for raising it, because when I was writing a specific paper, I read the literature, and there were some programs, even in Yemen and other Middle Eastern countries, where they have the WHO, the World Health Organization. They trained medical doctors in the university. They inserted in the curriculum of the medical doctors, or in the medicine degree, mental health modules, where they teach them on how to deal with mental health problems. So when you have students who are studying medicine, or students who are studying social work, or students who are studying nurse, for example, or even teachers, and insert in the curriculum mental health aspects as well as mental health modules on how to deal with mental health problems. And thus you will have more, let's say, practitioners who can help, as you said, millions of children who are in need of these problems. So that was very successful, actually, according to the WHO, when they inserted these into the curriculum of the medical degrees, nurse degree, or even for the teachers themselves, because teachers, they are dealing with children every day, and they face the children every day. So inserting this into the curriculum when they have their degrees, as well as later on for the teachers when they are teaching in the school, they can have some workshops to teach them how to deal with these situations. So yes, it's a very good recommendation.
Right, I'm just aware of the time. It's very interesting discussion. I'm enjoying it. But there's a repeated question for Dr. Fawzia, but I'm sorry, I don't think she's here with us now, so I'm sure she could be contacted via INTERYem to answer. Prof. Muthanna, you might know the answer. What is the percentage of the people who suffer from mental health in Yemen? Mental health disorders. I don't know if there's research.
Hello.
I think
is Dr. Fawzia with us?
Yes.
Oh,
yes.
please. Yeah. Alaikum assalam wa rahmatullahi.
So sorry, the connection here in Sana'a is very poor, and I couldn't follow all is this great discussion. Just I saw 13 parts from the wonderful presentation of Prof. Muthanna. It's really great, has very rich information, practical and theoretical information. Here in Yemen, really be more than happy to collaborate with him to get a great lesson and experience from his practical and theoretical and research in the area of mental health disorder.
Of course.
Regarding the percentage of mental health in Yemen, based on the research conducted by a family counselor, the percentage around 90.4, the percentage for mental health disorder among population. based on the study, a longitudinal study conducted from 2014 to 2017. This is the percentage, close to 19.4. This is the prevalence for
And
mental health
Fawzia,
disorder.
this is related to any mental health disorder.
A mixed mental health disorder is mixed
I think
psychology.
is it 90 or 19? 19.
19.
All right.
19.4.
Okay.
Yeah.
Thank you so much.
Yeah, I found a study, and it's very close to what Dr. Fawzia mentioned. If you want specifically in Yemen, I found that it is around 17% for depression and 15% for PTSD. So it is very close to what Dr. Fawzia mentioned about generally about psychological problems, 19%. But if you want specifically
PTSD,
the
actually,
W.
Yeah.
Yes.
For the PTSD, based in the finding of my study, we found that the percentage is very high. It's equal to 79%. 79 is really high. This is among the school children, IDPs, school children. About depression and the other is this is the challenge we face here in Yemen. There is a huge need for research, and we have very limited scientific sources about the prevalence of PTSD or other mental health disorder.
Thank you so much, Dr. Jose. That's very helpful. I think the last two questions I'll take, I think by this we answer nearly most of the, I hope all of the questions, is what adaptation could be done for the therapy in order to be delivered in Yemen? This is one question. And the second question, what do you think the role of the media and the schools just to help with the ongoing mental health issue in Yemen? Think that you could suggest?
Regarding the adaptation, actually there is a few psychosocial support intervention done by NGOs. They're using something similar what Prof. Mutanna mentioned, like using art, using drawing, using song, which call it the school spaces or yard spaces, something like that. So psychosocial support activities. This is the thing they did by social worker and certain project conducted by NGOs. This is the thing. Regarding the second question, it was, sorry, about what? The second
about
question?
what would you would be your advice for the media and the schools? What could they do to help with the mental health issues ongoing at Yemen? The media and the schools.
With mental health.
Dr. Fawzia, I think the connection is a bit poor. We can't hear you.
I can maybe talk a little bit about this till Dr. Fawzia comes back maybe.
Yeah.
There is a new program. Well, it's an old program, but it was developed later on to tailor to mental health problems, which is Sesame Street. And they started to do, to teach children through these series of sessions and TV program, to teach children how to differentiate between emotions of sad, happy, frustrated, angry, to teach children how to do belly breathing, for example, on how to do relaxation, There are some very good, really sessions or TV series that I can maybe put the link for this program. They interviewed me in the BMJ about the effectiveness of this TV program. They are now investigating the effectiveness of this program on the development of emotional problems, but also psychological, problems. And I found it very, very useful, because when you show this TV program for thousands and millions of children around the world and teach them on how to do belly breathing, on how to relax, on how to differentiate between being sad and being angry, because our problem really, and specifically maybe the Middle Eastern culture, is that everything is solved by anger. If you are sad, you get angry. If you are frustrated, you get angry. If you are even sometimes afraid or scared, you get angry. So teaching children, specifically those who are exposed to trauma, on how to differentiate between these emotions is very, very important, even for their future adaptation or life adaptation. And thus, this TV program is really good, because it is exposed to so many children at the same time, and it can teach them some techniques without the need of practitioners on mental health problems. It's Sesame Street. I think everyone, it's called Iftah Ya Simsim in Arabic. It used to be, I used to watch it actually when I was young. And now they turned it into a program that is more interactive with the children to teach them some psychological techniques. I can send you the link if you want that.
That might be very helpful. Right, okay. I think we have come to an end of this session. I'd like to thank our speakers, Dr. Fawziyya, Dr. Shakil, and Professor Muthanna for the very interesting talks, and for this very informative and helpful discussion. And I'd like to thank INTERYem for the great work and the effort. And we do apologize for any bad connections, internet connections or anything. We would just like to remind people that the conference is continuing, and I'm sure you'll have the program, so that day 2 starts tomorrow at 11:45 Yemeni time, inshallah. All the best for everyone, and thank you for those who attended today for your attendance, and I hope you find things helpful and beneficial. Thank you so much.
Thank you.
Assalamu alaikum.
Okay, thank you. Assalamu alaikum.